Good afternoon. I'd like to call this public hearing of the Committee of Health to order. Today is Wednesday, March 13th, 2024. The time is 1:01 p.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are in room 412 of the John A. Wilson Building, and this is a hybrid hearing with some witnesses testifying virtually and in person. We have one board nominee who will be testifying virtually and all of the government witnesses who will be testifying in person. Oh, in person. Oh, hi, Dr. Canavan. Sorry. He's here. At this hearing, we'll consider two measures under the committee's purview, PR25-0640, the Board of Psychology, Dr. Patrick Canavan Confirmation Resolution of 2024, and Bill 25-565, the Direct Care Worker Amendment Act of 2023. We will first consider the confirmation resolution before the committee before turning to the legislation. PR 25-640 nominates Dr. Patrick Canavan as a psychologist licensed in the district for a member of the Board of Psychology to serve the remainder of an unexpired term ending November 30th, 2024. Dr. Canavan currently oversees consulting services for Idea Crew, a health IT firm that developed the technology for the DC Health Benefit Exchange. This has included deploying IT-enabled behavioral health support in their first partner state, Massachusetts, aimed to improve outcomes for people in recovery from mental illness. Dr. Canavan previously served as the Chief Operating Officer of Howard University Hospital, the Chief Executive Officer of St. Elizabeth's Hospital, and Director of the District's Department of Consumer and Regulatory Affairs. Dr. Canavan earned his Doctorate of Psychology degree from the Illinois School of Professional Psychology, and he's a Ward 1 resident. So I'll call Dr. Canavan to the table for his testimony. Before you're seated, I do need to swear you in. So if you just raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? All right, awesome. Please begin when you're ready. Yeah. You just need to turn the microphone on in front of you. There you go.
Thank you. Good afternoon, Chair Henderson and members of the Committee on Health. My name is Dr. Patrick Canavan. I'm a mayor's nominee to the Board of Psychology. I'd like to thank Mayor Bowser for nominating me to this important position. If confirmed, I aim to support those members of the community who have concerns before the Board of Psychology and to support the psychology community in the District of Columbia. I'm pleased to be here today to provide testimony to the committee and to answer your questions. I am a 30-year resident of the District of Columbia, and I've lived in Ward 1 with my family since 2000. I was a longtime district government employee, as you have already mentioned, and a mayoral appointee, most recently having served on the Clemency Board, the inaugural chair of the Clemency Board of the District of Columbia from 2018 to present. I was a senior executive in the DC government, both at St. Elizabeth's and at DCRA, where I was the director of DCRA a long time ago. Prior to that, I worked for the mayor, creating a program called Neighborhood Services. And as you mentioned, I did work at Howard University Hospital, and I did work at Idea Crew. I now have my own consultancy where I'm a principal and owner of CNVN Consult, which is a healthcare and management consultancy registered in the district. And I'm also a partner in Capital Integrated Care, a healthcare management partnership that's newly registered in the district. I am a forensically trained licensed clinical psychologist and have worked at the Department of Behavioral Health and for residents of the district who are in recovery from behavioral health issues. At St. Elizabeth's, I led the hospital through a difficult period in which it was threatened with federal oversight by the U.S. Department of Justice. Over a 7-year period, our team revitalized the hospital by creating a recovery-oriented treatment program that focused on trauma-informed care. Not only did this transformation of care satisfy the Civil Rights Division of the U.S. Department of Justice, but it was also the right thing to do for those in our care and for the residents of the district. My work at St. Elizabeth's and in other leadership roles is directly informed by my knowledge, skills, and experience as a clinical psychologist. I believe that human behavior can change and that growth will benefit individuals, families, groups, and our community as a whole. If confirmed as a member of the Board of Psychology, my role will be to ensure the psychologists in the district are of high quality and well-trained. I also intend to be a support to the field of psychology as psychologists apply their knowledge, skills, and experience in the practice of psychology in its many forms. I wish to serve on the Board of Psychology to support my profession, to uphold its highest standards, and to make psychological practice a force for good as society helps individuals, families, and communities prosper. Chairperson Henderson, I'm proud to live in the District of Columbia. I appreciate the opportunity that Mayor Bowser has given me in the nomination to this board. I thank you and members of the committee for letting me provide testimony today, and I'm happy to answer any questions you might have.
Awesome. Thank you, Dr. Canavan. And thank you for your willingness to serve. I think I always do PSAs around the openings that we have on our 19 health professional boards. So it's always good when we have a good person who stepped forward. I do have a couple of questions and then you'll be on your way. So as you mentioned in your testimony, it's also online that you're currently listed as the chairperson of the DC Clemency Board. Do you plan to continue serving on that board?
No, it's my intention that if I am approved for this position, that I will resign from the Clemency Board.
Okay, all right. Okay, so the majority of your career, or I would say what we know in terms of your career, has been in a hospital facility leadership, including at Howard University Hospital and at St. Elizabeth's Hospital. Have you done anything in your background around providing direct care therapy services to clients?
Myself personally?
Yes.
Yes. So
Okay.
I came to the district as a psychology resident a long time ago.
Okay.
And so for the first 6 years of my time in DC, I was a direct service provider at St. Elizabeth's. So I did, the full array of training activities there, court testimony, all that sort of stuff. But in addition, I had a full client load at St. Elizabeth's of both working with severely and persistently mentally ill people who were inpatients at St. Elizabeth's and also in the outpatient departments at clinics that no longer exist, but were part of the DC outpatient system as well then.
Okay. So in your opinion, how would you say, how up to date or how current you are in terms of the current standards of practice and trends in the current space, whether it be someone doing private practice or providing direct service at a hospital or a clinic?
Yeah, I would tell you that, first of all, one of the requirements to maintain your licensure in the district is that you have 30 continuing education units every 2 years. It's a pretty serious undertaking and something that the Board of Psychology is directly responsible for enforcing.
Okay.
So your training must be updated, and that is serious, rigorous training every year, about 15 continuing education credits. So there's that. Also, I've been deeply involved in looking at transformation within the district and what are services that work. My work at Idea Crew also included developing curricula for competency evaluation, which is a deeply clinically based practice, so that competency is done in a way that is both in accordance with the requirements of the law, but also that really meets the standards of psychological practice. So I had to be fluid in those things as well. I've done a number of evaluations that way. One of the other roles that I held while at Idea Crew was I was the interim executive director of RAP, which is a substance abuse treatment program in the district during COVID. And so was directly involved in patient care while at RAP, doing a number of outpatient groups and trying to maintain what we were able to do in the residential facility there during that time.
Okay. One of the issues that has been a topic of hot conversation has been around the future use and role of telehealth, telemedicine. What's your view on telehealth as a modality of the psychology practice?
I actually was reading that today about the American Psychological Association has a fair amount of information out there about that and the efficacy of it as a evidence-based practice. And the evidence is starting to come in and starting to be developed. In general, I'm supportive of it because it makes psychological services available to more people in a setting that they can use. A long time ago, I was classically trained that said, if I'm not in the room with you and can't observe every single thing about what you're doing, I'm losing a lot of information about what could happen in the therapeutic interaction. I think that COVID has proven that that is sort of an obsolete notion. And to me, the availability of psychological services on a wider basis is key. If we can do it in a way that is evidence-based practice and we have the data that tells us it is, then we should go with it.
At a previous hearing, I had a conversation with Dr. Jimenez, who's the current chair of the psychology board, discussing the challenges around more parity in terms of getting more psychologists to accept Medicaid patients as part of their practice. Um, and he talked about, given the reimbursement rates on the part of DC Healthcare Finance, that makes it really difficult as some psychologists who are practicing in the field can earn so much without even having to deal with any insurance, right? With individuals who are just paying privately out of pocket. What are your perspectives on the ways that we can actually increase the number of people in the field accepting all types of insurance?
So, the insurance issue is a really tricky one. And on the public side, both Medicaid and Medicare have their reimbursement rates, and the district, when you stack us up against other jurisdictions, does pretty well. But it is really true that there is a workforce shortage across all aspects of behavioral health from my perspective, in particular, psychologists. And the work that psychologists do and bring to the table is a pretty unique one in terms of diagnosis and assessment and treatment. And so it's a broad range of skills at a pretty high level. I think that we have to have some kind of reckoning about what are we willing to pay for really high quality services that downstream will really reduce costs.
Yeah, I definitely would agree with you there. It's just always a how much?
Right.
It's always the question on that front. Um, so I am assuming that you've had conversations with DC Health around the time commitment to serve on this board, and you feel confident that you can meet the requirements, et cetera.
Yes, I feel confident about the farm.
Excuse me. Whew, excuse me. Yeah, fresh pollen is
Yes.
fresh. All right. Well, Dr. Canavan, I don't have any further questions for you. So I want to thank you for testifying before the committee today. If any members of the public want to submit statements on this nomination or the others pending before the committee, the record will remain open until 5 p.m. on March 27th. You may submit written statements via the council's hearing management system on the council website at dccouncil.gov/hearings. The committee has a markup scheduled for next Thursday, so we will take up your nomination then.
Great. Thank you very much.
Thank you. And again, thank you so much for your willingness to serve.
Thank you.
All right, we will now turn to consider Bill 25-565, the Direct Care Worker Amendment Act of 2023, which I introduced on November 6, 2023, along with council members Freeman, Parker, Pinto, Allen, Nadeau, Louis George, and Trayon White. This bill addresses workforce challenges in the long-term care, skilled nursing, and home health fields. Specifically, this bill would eliminate barriers to licensure and certification for direct care workers and establish a new minimum wage for individuals providing direct support for workers at 100% of the district's living wage. Certified nurse aides and home health aides provide crucial care for patients, including monitoring vital signs, assisting with dressing and bathing patients, and helping the patient move around their home or facility, among other services. CNAs and home health aides perform essentially the same function, but in different settings. CNAs are generally in a skilled nursing facility, and home health aides are generally in a patient's home. However, there are separate licenses that such a health professional must go through two certification process and maintain both certifications if they want to work in both settings. This significantly burdens direct care professionals, many of whom must take time off of work to complete additional coursework and become certified in the other provider type. This is especially problematic as workforce shortages in long-term care and home health sectors are nearing a crisis point. In 2023, the district experienced a significant loss of direct care workers, with 4,500 less CNAs and HHAs renewing their certifications in October 2023, which is 30% of the entire workforce. Providers are reporting severe understaffing at many facilities, causing them to turn away patients. This bill seeks to address some of these workforce shortages in long-term care in several ways. First, the bill directs the mayor to replace the fragmented certification system for HHAs and CNAs with a unified credential for direct care workers. Anyone currently working as a CNA and a HHA would automatically be certified as a direct care worker, or DCW. This change would eliminate the separate courses for study and the need to maintain two licenses. Second, the bill lowers the age for direct care workers to 16, a proposal also made by DC Health and the Health Occupation Revisions Act of 2023, which the committee is currently preparing for markup. While this bill would only allow direct care workers under 18 to work in a facility where they're supervised, the HORA provisions proposed by DC Health would allow them to also work in a home setting. Third, the bill would permit CNAs and home health aides licensed or certified in good standing in Maryland and Virginia to practice here in the District of Columbia. Providers from Maryland and Virginia were allowed to practice in the district during the COVID-19 public health emergency under a waiver of certification rules. Provider agencies reported that this flexibility alleviated some of the strains on the workforce with no adverse effect on the quality of services provided. Fourth, the bill would eliminate barriers to the development and use of on-job training programs and registered apprentice programs that can lead to certification as a direct care worker. Finally, the bill would establish a minimum wage for direct care workers at 120% of the district's living wage. The rates the Department of Healthcare Finance pays provider agencies will be updated to reflect the wage that the agencies must pay their employees. This new minimum living wage would replace the current mandatory average pay for home health aides. This convoluted system is difficult to administer and provides little transparency for employees. For example, under the average wage system, a home health aide receiving less than mandatory average can only assume that their lower wage is balanced by someone else in the organization receiving a higher wage. However, the individual would not have that information, so they could not hold the agency accountable. For agencies, there is a significant turnover in the payroll week to week. That means that they must recalculate their average wage on a frequent basis to ensure that they're actually, in fact, meeting the mandatory coverage. Overall, the streamlining of certification and licensure for direct care workers and the establishment of a minimum wage will move the district forward in addressing the long-term care workforce challenges. As population ages, the district must be prepared to support our residents that need assistance in their daily needs. I don't see any of my colleagues who are here, but should they arrive, we will certainly turn to them. I'm going to proceed now to the public witness testimony. Given the number of public witnesses we have to testify, all public witnesses will have 3 minutes. You are welcome to submit longer testimony for the record, but I hope that you will all be conscientious of your time. And I'll give you a nudge when your time has expired to preserve sufficient time for all public witnesses to speak today. All right, I will now call the first panel, which is not really a panel, but we do have some public witnesses for whom pre-recorded their testimony as they could not join us here in person or be on Zoom today. So we will play those witnesses' testimony at this time. So Peggy Nolan, Dolores Wood, Ellen Zavarenki, and Felicia Heigliger.
A member of one of the local DC villages and have been since 2009. My current medical situation has deepened what was a potential crisis before. I cannot, as my daughter said, manage right now and may not be able to manage with the various aspects of hygiene and other things that come up until one is mobile. I am not mobile. I cannot walk around the house. Yes, in the rehab facility, because the facility lacked enough help, they had to pile additional patients. If someone didn't show up, they had to reassign the number of patients, and those of us who were patients therefore were in a wider field for one person to do all the hygiene and the medications and the transport. Was that one would wait 2 or 3 hours for the hygienic services if you can't use the bathroom yourself. You have to wait. And they were so busy just distributing meds in that 3-hour block in the morning, they simply couldn't take the time to stop and do what needed to be done and the cleanup, and then separately serve the medication, serve breakfast, and handle 22 patients in a 3 or 4-hour block. And of course, it was difficult. They were lovely, gracious people working very hard. And sometimes they had to do a double shift because you can't really leave without anyone to replace you. Sometimes people couldn't or didn't show up. They're poorly paid, underappreciated. Higher pay might attract some people.
Okay, we'll go to Dolores Wood.
My name is Dolores Wood. I am 84 years old. But I have heart problems, I have asthma, and I have kidney failure. And I don't know what else. Rose, she comes, she helped me put my clothes on, she helped me put my pamper on, she helped me take baths. She did pretty good. She helped clean up the room. She did take care of me very good. If I don't have my family at work, I just have to wait until I can find somebody, or their company can find somebody to come in and work with me. If they can't find nobody to come in and work with me, I'm just here by myself. Why can't I go downstairs by myself? And I can't go to the bathrooms by myself. So I just have to stay here and wait till somebody comes. Either I call my son-in-law, and he would just leave his job and come to see what's wrong, with me. If the agents try to find somebody and they can't find nobody, then I'm just here.
Okay, and we'll now hear from Ellen Zarimski.
I went out on FMLA leave from my job in Ohio. I live in Columbus, Ohio, because my mother had her leg amputated. And my mother is 90 years old and lives alone in her home. And without a leg, it means an additional amount of care. And that included me. So I took off 2 pay periods, which is a big hit to me and my family. But it was needed to be done because I found that managing both my job, my home life, and my mother's life, and all the care that she needs was impossible and too stressful. Means that I have to be here to go through insurance plans, to have all the banking coordinated, to, if somebody cancels when we have an aide scheduled or they can't find somebody to come in, I'm the person that's responsible for taking care of my mom's health. So for us, we're finding that the weekends are the hardest, the weekend mornings, Saturday and Sunday mornings. So my mom would spend the whole night, we'd have a family member here, wake up, there's no care for her. So I'm the one that has to change the diaper. I'm the one that has to make sure that she can be cleaned, throw away everything. That means she's bedbound, how do I change her? How do I roll her over? I had to learn all these skills that I'm not very good at and that my mother did not want me to do. And can't tell you how thrilled I was not to be doing this. But these are the things that you end up having to do when you can't have the care.
And finally, Felicia Heigler.
Hi, my name is Felicia Hagler. I live in Washington, D.C. I've been home health aide for over 25 years, but I have been caring for people all my life. I love helping people, coming into their house, getting to know them as a person and helping them with their everyday needs, such as bathing them if they need it, clothing them if they need it, taking them to the doctor if they need it, sitting down talking to them or having a regular conversation with them because they are people too, regardless of the disease. All in all, I just enjoyed what I did, but the companies that hire us don't do enough for us, such as giving us sick leave, annual leave, and the money sucks. So anytime a person is doing this, they're doing it because they care for the individual, because if it was about the money, you would have no one doing it.
Okay, so those were the 4 video testimony recordings we received. I want to thank Sal Savegio, who helped facilitate the ability for those residents to be able to provide some testimony today, which I think was very helpful. All right, we're going to go to our next panel. So we're going to do panels of 8 first, and then we'll switch to 4 because I only have 4 seats. That's right here, but I have actually, we're gonna have to do 7 for the first one. Okay, so I have 3 people who are online. William James John Claude, Kevin Moats, Burke Dillon, and then for here in the room, Marla Lahat. Okay. Ian, excuse me, Susan Sedgwick, and Mary Proctor. Okay, and for the first 3 witnesses who are who are virtual, you'll need to affirmatively accept our invitation to become a panelist in order for you to appear on our screen. Okay, while we figure out the virtual, we'll start with our folks in person. So Marla, when you're ready.
Good morning, Chairperson Henderson and members of the Committee on Health. I'm very pleased to be here today to provide testimony in support of the Direct Care Worker Amendment Act of 2023. I'm Marla Lahat. I am the Executive Director of Home Care Partners. Home Care Partners is a nonprofit home care agency that provides 3 services through generous funding from the DC Department of Aging and Community Living that are designed to help older adults remain in their homes. The Homemaker program that provides certified home health aides to older DC residents who do not qualify for Medicaid-funded services, the DC Caregivers Institute that supports unpaid family caregivers, and the Safe at Home program that does home modifications and other fall prevention activities. Home Care Partners is a proud member of the DC Coalition on Long-Term Care
and an active member of the subcommittee that focuses on workforce issues. I believe Chairperson Henderson, you've already described the problem, the workforce crisis. I'm not going to repeat that, but I did want to provide some testimony in support of the act from the perspective of a provider. As a provider of home care services to low and moderate income DC residents, we can confirm that this is the most severe workforce crisis that we have faced in our 67-year history. We post jobs continuously for home health aides. Our job postings prominently advertise our starting wage of $18.90 an hour, which is more than most are paying, and our $500 sign-on bonus. We get many responses to our job postings. However, the majority do not have the required DC home health aide license. Many have Maryland and Virginia CNAs. These are passionate individuals who want to work but face barriers working in DC. Passage of the Direct Care Worker Amendment Act of 2023 would be a huge step forward. Among the most critical components, raising wages, number one. That is most urgent. The wages must be raised, and it should be considered a floor, not a ceiling. Like any industry, these workers need to have a progressive wage scale. Number two, creating the universal training certification for home health aides and CNAs and expanding the reciprocity with Maryland and Virginia. Because Home Care Partners provides services in all three jurisdictions, we know that CNAs in Maryland and Virginia have comparable training and skills. During the PHE, the public health emergency, Maryland and Virginia CNAs were allowed to work in home care, and they should be allowed to do so again. I see my time is just about up here, but removing training barriers and supporting on-the-job training programs is another component that is so critical. We have many inquiries from people who want to work in this field but need the training. Finally, I do want to say that there is a misconception that these jobs are not good jobs or dead-end jobs. That is simply not the case. There are many individuals who want to work in this field. They have personal experience, and I can tell you at Home Care Partners, we have promoted many of our aides to other positions within our agency. Finally, I do want to thank you so much for putting forth this bill. I think it's an excellent bill, and I look forward to working with you.
Thank you. Thank you. Okay, I now see Kevin on. Kevin Moats. Kevin, if you're speaking, you're on mute.
Can you hear me now?
Yes.
All right, how you doing? Well, I just wanted to say, I gave a virtual, you gotta forgive me, my voice is kind of messed up. I gave a virtual for this meeting, and I was basically coming from both ends of it. I had also had aides to come into my house, and I had to also bring family members in. And when we have this shortage of aides coming into your house, it really puts us in a loop, because at the end we have no one to come in. You heard a couple of testimonies on that about no one's being there. You have to stay in the bed and so forth and be home. A lot of them was elderly. I have muscular dystrophy, and I'm 58 years old, and I've been like this since I was 23. And my cousin was the same age as me, and he carried me for 15 years by himself before we even had someone to come in to help with me. And at the end, I think that we all need it, because I was working for DC Public Schools when this happened to me. I would have never thought that I had muscular dystrophy, but it was in me all the time. I was born with it. And so at the end, we have to be like that movie, A Time to Kill. Sometimes we have to think about if it's us. You know, some things we just need to put in our mind that we all may need it. And so we really do need to pass this bill of Acts of 23. And I really don't have too much to say, because I'm not feeling too well today. But that's it.
Thank you, Mr. Moats, for being here. Burke Dillon.
Hi, thank you for the opportunity to testify today. I care about this. I'm 79 years old. I've lived in DC for 50 years and I live in Ward 2. I'm a member of the Foggy Bottom Village, but most importantly, I live alone and have absolutely no family. Over the past year, I've had 3 major surgeries, 2 of them emergencies, spent 8 weeks in hospital and 2 weeks in skilled nursing. I'm now in a wheelchair with full-time aides. I need their help to wash, to dress, to prepare food, for anything. In the past year, I've paid $240,000 just for my aides. I took a second mortgage on my condo to pay for it, but I am lucky. I have medical insurance and I have a condo that I can mortgage. But even in my fortunate position, I've had to struggle to get regular and reliable home care. Most home health care workers cannot afford to live in DC, so they travel long distances at all hours and then cannot find safe, affordable parking. This is true for many cities, but we are a city with no state. In addition to the commute, workers from Maryland, Virginia face the problems and costs of getting licensed under a separate regulatory regime. Given the demand for these workers, it is no wonder they say, why bother with DC? As the chairman said, just last year, we lost over 4,000 licensed workers in DC. I've had days when the agency could find no one to come to my home. I could not leave my bedroom. Friends had to bring food. They had to help me to the toilet. I feared another medical emergency with no one here to help. When I was a new client, I had more than 50 different aides in 5 months. You wake up to a strange face every day. They don't know you or your condition or where anything is. Some aides left for different jobs, but others jumped at the first chance to switch to a client closer to home. Even my hospital discharge was delayed because they could not find a spot in the understaffed nursing homes. What do we need to do? I think from talking to everyone, we need competitive pay and we need regulatory agility. We must make it worthwhile for aides to come here from Laurel or Lorton and remove any obstacles to their working here, even on short notice. We need to train and develop new home healthcare workers and have a pay scale that encourages them to stay in the profession. If we want, as the mayor says, an age-friendly DC, we must do better than we have been doing. If not, the crisis is just going to compound. Thank you, Madam Chairman. We are counting on you.
Thank you, Ms. Dillon. Ian?
Good afternoon. My name is Ian Paragal, and I serve as the Executive Director of the DC Coalition of Disability Service Providers. The DC Coalition currently represents over 50 provider agencies, and it's the largest provider collective you'll hear from today. There are several non-fiscal provisions of the proposed legislation that have no impact on the members of the DC Coalition, and we support them. However, there is one that is central to the draft as presently written, which is of great concern, the modified hourly minimum wage calculated at 120% of the living wage. The DC Coalition is deeply concerned about the language of that provision, and we're desperately trying to avoid a number of unintended consequences that would arise if the bill is passed as it is written. In 2018, Councilmember Nadeau and I developed earlier similar legislation, the unanimously passed Direct Support Professionals Rate Payment Act of 2019. That act purposely created space for career tracks, recognized tenure as well as excellence, and revolved around a construct that maintained flexibility for the provider community while still attaining the goals of increased wages for the frontline workers. Unfortunately, today's proposed legislation may undermine those goals. The bill creates a floor and, quite frankly, a de facto ceiling for wages, and the passage of the proposed bill without addressing the need for an appropriate wage scale will not only adversely impact the objectives of the 2019 legislation, but also cause an already fragile industry to crumble. Just so we're clear, when DCHCF has been given a wage funding mandate in the past, they have funded just to the level of the mandate. And you will hear that today. That's their expectation. That's what they're going to testify to. Unless direct language within the proposed bill includes an expectation that DCHCF will allocate funding so that the base is 120% of the living wage, with an average point well above that mark and then an upper end target in perhaps the 140 range. The career pathways, tenure, training, and excellence targets from the original DSP Rate Payment Act will be lost. We're still in the first year of implementation of the 117.6 average wage scale that was born out of the Rate Payment Act. Some providers, in the interest of ensuring that compliance with the requirements for the enhanced DSP wage models, simply shifted their all employees to a midpoint scale of about $20 an hour. But many DD providers have been building tiered career systems in order to develop retention and recognize excellence. The DC Coalition is proud to note there are many employees who earn well more than 120% of the living wage. What happens to them if this legislation goes through? Because the current language of the bill is being interpreted by DCHCF as establishing a funding ceiling, this will result in a devastating impact that will eliminate the ability of providers to pay more experienced workers higher wages. In short, retention would be wholly unfunded, and that alone would have a far worse consequence than having no legislation at all. The wage tiers that we fought to establish would be flattened, and the exodus from the industry would only be hastened. In conclusion, with all due respect, the language included in the bill, the way it is drafted, is not the answer. When we have previously shared these concerns about the bills, we were assured that the intent was never to create a funding ceiling, but we are afraid that may happen. We believe it's important to get the language corrected now because the details are needed in order to create a more accurate fiscal note for proper analysis and funding strategy. And of course, I welcome any questions.
Thank you. Ms. Sedgwick.
Thank you, Chair Henderson, and members of the committee for allowing me to testify today. More importantly, I want to thank you for introducing the Direct Care Worker Amendment Act of 2023. The bill you've introduced recognizes and provides actions that, if implemented correctly and in a timely manner, will help alleviate the current shortage of aides. I've tried to shorten my submitted testimony to 3 minutes, so here we go. My name is Susan Sedgwick. I will be 80 years old this year. I have been living in DC since I married 45 years ago. My husband, John, is now 84, has lived in DC over 60 years. Our son's family, we're very pleased with this, has remained in DC. DC is home. In 2017, Capitol Hill Village learned about the shortfall in the home health care aide workforce, the workforce that my husband and I are counting on to help take care of us as we get older. We learned and we did a lot of study. We learned a lot of things. We met a lot of really great people. And we learned that no one in the administration is in charge or willing to take a leadership role in bringing the siloed agencies that affect this workforce, bring them together. That situation remains today. Your attention should encourage the administration to act. Why am I concerned about this? John and I are trusting that we'll be able to hire trained aides, and that's very important to us. We want to minimize the burden of caring for us that our son and his young family will probably have to bear some aspect of. My submitted testimony provides several instances where I have experienced the support that qualified direct care aides can give a family. The first is about my uncle and how his 77-year-old wife sat with him the nights when an aide did not show up. The second is about my mother and how her having an aide kept me from having to take extended leave and time off of work. In her final days, spent at a rehabilitation facility, we were able to hire an aide to supplement the facility's overworked staff. Mama's aide gave her the professional attention she needed and deserved. Mama was as happy as she could be, and her happiness meant everything to us. I want to recognize this critical healthcare workforce is primarily made of people who are Black, brown, and immigrants. The historically low pay these trained certified workers receive should be considered a systemic equity issue. We can do better by these workers. Raising the wages so these jobs can be considered good jobs would be a start. My ask, pass this bill. Some of the language may need to be tweaked to ensure the bill is implemented the way the council intends it to be implemented. Others steeped in labor and workforce policy, some of whom are testifying today, can offer alternative language. Thank you very much for this opportunity.
Thank you. Ms. Proctor?
Good morning, Chair.
Oh, if you just turn on your mic. And Ms. Sedgwick, if you could turn yours off. There you go.
And I'm going to change my greetings to good afternoon, Chairperson Henderson and members of the committee. My name is Mary Proctor, and I'm a member of the Capitol Hill Village Advocacy Team. I am also testifying on behalf of the members of the Coalition on Long-Term Care's Committee on Workforce. which I've belonged to for more than 4 years. We are very grateful for the Committee on Health sponsorship of the Direct Care Worker Amendment Act of 2023. We believe that if passed and implemented promptly, it will make a significant improvement in the availability of skilled direct care workers. My testimony is in support of this act, number B25-0565. I urge that attention be paid to the testimony of the 7 witnesses that began this hearing, all dealing with disabilities and often bedbound, dependent on direct care workers in their homes or in rehab or nursing facilities. 4 of these people testified by video and 3 testified virtually. And I might add that the next time there should be some attention to loudness. These are the people who should be listened to about the crisis. They and their families really suffer when there aren't enough direct care workers. And I'm very appreciative of the Committee on Health staff for making their testimony possible. My husband and I are both 82 years old. So far, we are healthy and don't need direct care workers at home or in a facility. But in our 80s, some of our friends have suffered strokes or a dangerous fall that leaves them bedbound. We know that we could end up in bed at home or in a facility for the rest of our lives. I've been alarmed by data from the DC Board of Nursing that the number of certified DC direct care workers in facilities and in homes dropped from 2022 to 2023 by more than 4,400 workers, a share of more than 30%. Meanwhile, the DC Council's Office of the Budget Director warns that the number of older adults could increase from 2019 to 2030 by about 25%. We love living in DC, but should we be looking for another place to grow old? Our fears will be eased when the DC Council passes the Direct Care Worker Amendment Act and when the Bowser administration takes it seriously. Thank you for this opportunity to testify, and I'm ready to answer questions.
Thank you, Ms. Proctor. We've been joined by James Jean-Claude online. James, if you're speaking, you're on mute.
Okay, there we go. Oh, thank you for your colleagues who've helped fix the technical difficulties. My name is James Jean-Claude. I'm a 53-year-old DC resident. I've had a more difficult pandemic than most people. On 5/7/2020, I had back surgery. I woke up and they told me I was paralyzed from my belly button down. From that point, they weren't sure if I would ever walk again. One day I wiggled my toes, gave them enough hope to send me to National Rehab, NRH. And then from NRH, I spent a month there during Q rehab to going to a nursing home. I spent approximately 6 months at a nursing home called Manor Care in Chevy Chase, and it was hell. Being in a nursing home during pandemic was the worst in hell. As you know, nursing homes were a hot zone for pandemics. So I had a terrible experience of a nursing home, and I had to reach all these milestones to get discharged to go home and recuperate there. I finally did everything that was necessary to go home, but to my chagrin, the home care that was supposed to be set up for me was not set up properly. And my first 4 months at home were without any aids whatsoever. So my 73-year-old mother had to take care of me for the first 4 months. Thank God, finally, the kinks and bureaucracy got fixed and the aids got sent to me. And aids have been a blessing to me. They're so necessary to me. I need them for everything in my life. They help me bathe, they help me dress, they get my food, they help me with the administration of my medication, and et cetera. And even when I go out and about, they help push my chair. and help me and my doctor's appointments, navigate to help assist the doctor. But getting AIDS has been inconsistent, and there have been many causes for it. And I know that the purpose of this bill is to help alleviate some of the problem. And I am grateful for all those who are trying to move this forward. The biggest two problems that I have with home AIDS situation is availability and competence. Availability, just to give you an example of how bad it's been, just in the last few months, just since January. In January, there's 4 days that I went without AIDS. And in February, there was 1, 2, 3, 4, 5, 6, 7, 8, 9 days that I either went without an aid for the full day or for a half day. And this puts my only safety net is my 76-year-old mother, who has to take care of me when the aid is not available. And as I said, I need aid to help me with everything. And I weigh almost 300 pounds. So helping me with my bed mobility and moving around, changing my diapers. I use the diapers. So imagine how many times a day you use a bathroom, 3 to 4 times a day. So that's how many times my diaper needs to be changed. And that is a production in and of itself that takes 20 to 30 minutes each time. So I'm so dependent on AIDS, and it greatly affects my quality of life. And so that is just a problem with availability. And then there's an issue of competence. The workforce, because this industry is so desperate for workers, unfortunately, a lot of unqualified people slip through the cracks and end up caring for us. And I've had situations where people have tried to wash me without soap. And mind you, again, I say I use diapers. So if I'm not cleaned properly, I'm at high risk for infection. And if I get infection, it could deteriorate to a situation where it gets a sepsis, and people can die from such infections. So, when I was in the nursing home, I got those infections and UTIs all the time because I wasn't cleaned properly or regularly. I mean, there are times in the nursing home I would be sitting in my own feces or my soiled diapers for 5, 6, 7 hours at a time. And so, which in each passing hour greatly increases in chance for infection. I've had aides who come here who said they've never changed diapers before. I mean, that's the first thing they should know when they come to deal with me, is that I use diapers and how to change them. English level.
Mr. Jean-Claude.
Oh, you're short. Okay, I'll be quick. But essentially,
you're already over your time. But if you could hang
Okay.
on, I'll ask you some follow-up questions if that's okay.
Sure.
You're about 2 minutes over at this. But I want to thank all of the public witnesses on this panel who have testified. I think that Mr. Jean-Claude, Mr. Moats, Ms. Dillon, I appreciate you all your willingness to share your stories. And I think it underscores just how important this issue is, but also how overlooked this issue is as well in terms of its level of focus. A lot of people don't think about these particular issues until either they know someone or they need the service themselves. Ms. Lahat, I wanted to ask, since your organization, okay, good, she put me on a clock. Since your organization provides services to clients in all 3 jurisdictions, is the workforce shortage a unique thing to DC, or is it something that those jurisdictions are also facing as well?
It is not unique to DC. It is certainly spread out throughout the country, actually. But in this tri-state area where people live in one jurisdiction, they work in another, we need to have that portability Many of our workers want to work more than one job, or they want to work in more than one jurisdiction. And so I think this bill at least addresses that need.
Okay, great. Now, Mr. Paragal, I thank you for your testimony. I think as we sort of communicated before, it was certainly not our intent to create a ceiling. But I think you make a good point in terms of if DC Healthcare Finance is interpreting it in that way, then we need to address that. It was always our intention to raise the floor.
I'm sure of that.
Okay.
But I do know what the interpretation is, so.
Okay. Ms. Sedgwick and Ms. Proctor, thank you so much for being here and for your testimony as well. I'm curious in terms of the friends that you might have in other jurisdictions. Is this an issue that they are also talking about? Similar to the question that I asked Ms. Lahat, I'm trying to determine, is there something different about DC, or is this something that is a struggle all over the country?
I can't really speak to other jurisdictions. I have a couple of anecdotes where I have friends who are taking care of a disabled son.
Okay.
And the story that you heard from Jean-Claude was very similar to they have an 80-year-old mother has to be the backup for taking care of a man who's a quadriplegic. So I have that story, but they do have to be the backups. They have a whole series of personnel that come in to help, but still there needs to be that backup. I think that here DC becomes a little more different because there doesn't seem to be an integrated approach. In other jurisdictions, we're hearing about states taking on these as an issue, as a totality issue, and taking a look at all the parts that need to be addressed. And that's where we're very disappointed in that we can't seem to get the attention to have do an integrated approach to this problem in DC.
Okay. Can you say more about what you're hoping for from an integrated approach standpoint?
So, I'm sorry.
Can you say more about what you're hoping for in terms of integrated approach?
Well, I'll tell you, the experiences we've had working with workforce issues is going to the Department of Employment Services and finding out they have training programs. And they were, at one time, this was several years ago, they were coming forth with the training program, and they hadn't talked to the Board of Nursing, the Department of Health, as to what ought to be in that training program. Okay, that's one item. Okay, so let's waste of time. And then you have other, in more recent times, that we hear from, I guess, the Deputy Mayor for Education saying that he's only going to make sure that, and I think this is fair, that the city invest in good jobs. And good jobs have a minimum wage scale. And so, and we hear that these jobs are not considered good jobs. They're not, we hear that they're not eligible for going after federal labor department money to help them develop because of the good jobs. But why are they not a good job? It's because DCHCF has put the clamps on, or at least my interpretations, put the clamps on how much the reimbursement rate is. And then there's those of us who are basically going to be private pay. You know, we're not Medicaid people. What does this mean? Why do I care about this? It turns out the Medicaid element of supporting the caregivers and doing that makes the market for caregivers.
Yeah.
And that's a hard concept to understand. It requires a lot of business aspect, but making the market means that training programs, the private training academies will gear up if we are able to raise this rate and let it make the market, and then we can have more people trained, et cetera, et cetera. So that's where the silo thing comes in. And I think maybe even within the Department of Health, but the HORA business versus the Board of Nursing, and it gets complicated.
Yeah. Okay. That's definitely very helpful. I'm trying to model good behavior and stay on in my time as well. So I don't have any further questions. I hope that all of you please submit your written testimony for the record so that we can have that for fulsome conversation. But thank you all so much for being here. I really appreciate you sharing your stories and your testimony. I'm going to continue with the in-person. Neil Richardson, Claudia Balog, Judy Berman, and Eddie Masello. Okay, I can call her for the next panel. Okay, Mr. Richardson?
Good afternoon. First of all, I want to thank you, Councilmember Henderson, for creating this legislation. This Direct Care Worker Amendment Act of 2021-23 is a fantastic piece of legislation. And your leadership on this issue and many other issues are very much appreciated by many folks around the district. I just want to thank you for that. So my name is Neil Richardson. I'm Deputy Director at DC Appleseed. Today, though, I'm also testifying as the acting coordinator of the DC Coalition on Long-Term Care. The coalition works to expand and improve the quality of long-term care programs and to ensure that district residents living on low incomes and with disabilities can age in the community safely and also with dignity. The coalition comprises over 80 organizations and stakeholders, bringing together consumers, advocates, and healthcare providers to work with district government on long-term care issues. DC Appleseed supports the efforts of the coalition to ensure all DC residents can access affordable and appropriate care, and their efforts to improve training, work conditions, and compensation for DC's long-term care workforce, which we think that this Amendment Act 2023 will go a long way. So some of the questions that you asked some of the witnesses earlier about whether this is a unique problem in the District of Columbia, it's actually a problem all across the country. There's a problem with hiring enough healthcare workers at every level, all the way up to doctors. And so one of the ways that we can alleviate these problems are creating really good pathways, education pathways that have pay standards that have some incentives for workers to go forward. So last year, I think we heard in the context of this earlier, 4,500 workers left these jobs as CNAs and home health aides. If we had a third of the police and nurses leave their jobs, this would be a crisis, yet there are those in the administration, there's a deputy mayor for education saying it's not a good job, it's not a crisis. Well, it is a crisis. I'm going to read, I think a lot of my colleagues here are going to talk to you about the specifics of the bill, but let me just give us some of the numbers for folks that are listening along in TV land. We have 36,000 DC residents who require some form of direct service health care every day. 19,500 are between 18 and 64 years old. 16,500 are 65 years old and over and unable to live independently. And these numbers are getting worse and worse every year as this country and as this city ages and becomes unhealthier. So I'm out of time, but I will just say in closing that the first thing that a government is supposed to do is take care of its most vulnerable residents, and we are not doing that. So thank you.
Thank you, Mr. Richardson. Claudia?
Good afternoon, Madam Chair. So thank you for the opportunity to testify on this bill. My name is Claudia Baylog. I'm an Assistant Director of Research with 1199 SEIU, United Healthcare Workers East. We're the largest healthcare union in the country, representing 400,000 members from Massachusetts to Florida with thousands of healthcare workers in the district. I'm submitting this testimony on behalf of all healthcare workers who are struggling to survive on poverty wages, while consumers who depend on them face the impact of these severe staffing shortages. We support the Direct Care Worker Amendment Act because it's such a necessary step in addressing the documented direct care staffing crisis that the district faces. We also want to make clear that while raising wages for these workers is important, Creating a progressive wage scale that recognizes workers' experience and credentials is equally important. We are going to reiterate the call that the bill clearly lay out a new wage floor, not a ceiling. So I want to talk a bit about our members who include CNAs at skilled nursing facilities who often moonlight as home health aides to make ends meet. We know from the perspective of our members, their skills and experience allow them to jump from one care setting to another. We also know they make that decision to work across multiple care settings because their wages are too low. I'm going to shout it to the hilltops again. This is an equity crisis when you look at the number of women and women of color and increasing number of immigrants who are in these jobs who are also dependent on lots of forms of public assistance. Now, our members in skilled nursing facilities have experienced drastic changes in their day-to-day work. The acuity levels of residents in skilled nursing has increased. They're caring for residents on ventilators with trachs who need wound care or services in memory units, and that's why these higher demands of the jobs need to be reflected in their pay. I'm going to pivot. I have submitted a lot of written testimony about states across the country that are trailblazing on this, and I'm so excited that the district is joining them. There's three things to note about states that are really trying to address this problem. Number one, they're trying to address the wage and working conditions across the long-term care industry, not just siloed in home and community-based services or congregate settings. Number two, they're looking at wages that reflect the skills and experience of caregivers. And number three, you asked this question earlier, the approach includes a strong government executive level engagement that's characterized by multi-agency collaboration. I'm going to take my last few seconds to shout out three states. Maine is an incredible example of a state that's engaging in the kind of multi-agency collaboration necessary to make this happen. Illinois and Tennessee are both states that are really thinking critically about progressive wage scales linked to experience and credentialing. I'm here for any questions that you may have. Thanks so much.
Thank you. Ms. Berman?
Good afternoon, Committee Chair Henderson. My name is Judy Berman, and I am the Executive Director of Capitol Hill Village, an organization that supports residents of the Capitol Hill area to remain active, engaged, and valued as they age in our community. Capitol Hill Village is one of 13 DC villages, all of which are working to build communities where older adults thrive. I am also a 25-year resident of the district, and at age 60, I am carefully assessing the options I have ahead of me, thinking about what it means to be able to age well and where I will have the best chances of doing that. I know I'm not alone. I should also mention that I'm part of the care team for my father, who's almost 96, who lives in Florida and depends on the services of a paid caregiver. I joined Capitol Hill Village in late 2019, just 3 months before the pandemic changed everything and showed us just how little older adults in our communities are valued. Before that, I was the deputy director of DC Appleseed for 14 years, where I focused on policies that would improve outcomes for working poor families and which specifically included those families led by direct care workers. I support the Direct Care Worker Amendment Act because it includes practical, achievable changes that will improve the lives of those working in direct care positions, as well as those who depend on them for care, which, let's face it, will include most of us at some point. I support providing an increased wage as a floor, a minimum. 120% of the living wage is the very least that individuals deserve for completing training, getting certified, and undertaking the physically and emotionally labor-intensive work of caregiving. This effort will put money in the hands of the Black, brown, and immigrant women who perform most of this work and who are severely undervalued. I support allowing qualified workers from Maryland and Virginia to work in DC and help us fill the gaps in our workforce immediately. The number of people available to fill these jobs in DC is declining sharply, as you've already said. Nearly 4,500 registered direct care workers left the workforce. I support this arrangement because at Capitol Hill Village, we see what happens when aides don't show up and no replacement is available. And we heard from folks who are in that position. When an elder with paralysis spends an entire day in her bed, unable to get to a bathroom, unable to take her medication or adjust her oxygen. When an elder with moderate dementia loses weight she can't afford to lose because an aide isn't there consistently to make sure that she eats. When an orthopedic patient in rehab has to wait hours before someone comes to take her to the bathroom, at which point they're changing bedding instead. I also support requiring the mayor to remove barriers to opportunity. Expecting Maryland and Virginia to make up for our failure to invest in and train enough workers doesn't address the real problem. There is a failure of leadership here. This district needs someone to own this issue, to make the leadership of DC Health, DHCF, DACL, DDA, DOES, OSSI, and UDC, and there may be more, sit down together to figure out how we're going to build a workforce to care for the growing number of individuals who will need care in all settings: home, hospital, rehab, assisted living, and nursing care. If we don't start positioning direct care as an on-ramp to an effectively designed and supported healthcare human services career pathway, this problem will persist and likely worsen. I want to thank you, Councilmember Henderson, and the co-sponsors of this bill for bringing attention to this vital issue and offering solutions that will make an immediate difference. I am happy to answer any questions.
Thank you. Eddie?
Thank you, Chair Henderson. My name is Eddie Masello. I'm the Area Vice President of Maxim Healthcare Services and a Ward 5 resident. Maxim Healthcare, we are a nationwide home care agency, and we operate here in the district. My oversight extends to Virginia, West Virginia, South Carolina, and Georgia. We provide private duty nursing for and personal care services across the district. And we support the unification of the DCW credential. We just think it just makes sense. So that the current setup is convoluted, and you know, we understand the intent of why it went that way, but it has I think kind of borne its course. And we also support like the possibility of engaging with Maryland and Virginia caregivers. We think that just opens up the swath of folks that we're able to recruit and we're able to place in homes, folks that want to be in caregiving, not just folks that are in it for a job. However, while we applaud the intent of the 120% of the minimum wage, we do have the same concerns and cautions of DCHCF and the funding, looking at that as a cap, as a ceiling, as it's been said. And we really want to urge, you know, council on really the implementation of this and not making that, not having the execution be sloppy on it. And that means that we have to continue to be able to offer a progressive pay scale. We have to continue to, you know, invest and reinvest, not in only training and career pathway, but also things like benefits, being able to keep up with some of the things that our counterparts in commercial industries can do. You know, and you know, as you've probably heard too, like their challenges still remain with the winding down of the PHE and the overtime rate flexibilities. We think that passing this with the adequate funding will help reduce some of the staffing burden, but again, only if the funding is in with lockstep of this legislation. Thank you for your time.
Thank you. And thank you to this panel in terms of the issues that you raised and of course, the expertise that you bring to the table. Mr. Masello, I'm curious, since you do staffing, well, your region covers all the way, I think you said, to South Carolina.
Correct.
How do you view what's happening sort of in our region versus what's happening in some of the other places? I think you have an interesting perspective.
It varies state by state of who's actually invested in the community. We've seen this, like for example, Virginia 18 months ago made a significant investment in reimbursement rates that we've seen. We've seen us be able to really compete against facility-based type of providers in order to deliver them at the bedside or in the homes. And then, you know, other places where they just don't invest in it much, and they frankly don't have the same programs as they do in DC, such as EPD waiver and DD, where they have consumers have a fairly big access to folks in their community, right? To where they can get caregivers around the clock, whereas some states might cap those at 25, 30 hours a week, and they choose to institutionalize those folks. So it, you know, it's certainly varied from state to state, and it's a, you know, if you would like more nuance on it, we're certainly happy to give you our expertise on it. But we've seen states that really invest in funding the programs. We've seen the providers follow suit and being able to compete for those caregivers, because if you don't reinvest in your caregiver population, you can't function as a provider.
Yeah. And the reason I ask in sort of some of these is because for whatever reason, this is an issue that is at the top of the list when people sort of talk about issues around human services. We'll put this in just sort of the human services bucket, and wanting to understand, are we behind? Or I feel like we're behind. I do. I feel like we're behind, especially when we say for DC that it is a value of ours to allow for folks to age in place. And yet we haven't invested in the infrastructure that actually allows for that to happen fully.
I would say you guys are probably in the middle.
Okay.
Yeah.
Appreciate that.
Yeah.
Give us a greatest on a curve.
I think it's a largely, you can legislate some of it, right? But you can't do much without the budget.
Yeah. Yeah. And I think that's important too. And you raised that as well, Claudia, right? Like, and a little bit of the conversation I was having with Dr. Canavan at the beginning, the nominee for the Board of Psychology, we'll see like reimbursement rates drive this conversation in a big way. And when we're trying to reimburse pennies on a dollar, that's what you get, pennies on a dollar in terms of the return of investment on that front. Judy and Neil, I want to ask you guys, because you sort of, Judy from your previous work and Neil from your current work, you guys have sort of been in the DC circles a lot. The type of coordination or leadership that you were talking about, Judy, isn't that what Age Friendly DC was supposed to be about?
I don't think that Age Friendly DC has the authority to do that. The concept, yes, but we're talking about convening, like high level actually requiring coordination. And that means working, with trustees at the board at UDC, it's just not, Gail Cohn hasn't been given the authority, I think, to do this kind of work.
And there's a lot of complexity that it's not easy. And so we need a convener who has the authority to bring folks together. But when you're talking about creating a curriculum at UDC for home health for CNAs, that it could be approved by also Maryland, Virginia, that takes a conversation. And then we have to figure out, we have to work with DOE, the district government needs to work with DOES to make sure we can figure out a way to recruit workers that want to take those jobs. We got to go back and talk to UDC to try to recruit the students that want to take those classes. And then, you've got to have, healthcare finance, hopefully raising the wages and paying appropriate wages. And the deputy mayor for education needs to agree that we're in a crisis and that these are actually valuable jobs and essential jobs for many of our residents. And so if we keep trying to fix these kind of problems in district government piecemeal, we will never, ever fix these things. I've been in district government for 25 years, worked with 3 mayors, and we fixed things in a piecemeal in one part, and then the whole is still broken. We've got to bring everybody together.
Yeah, I definitely would agree with that. I mean, I think some of the things that you were talking about, I will say this, it is difficult, if not impossible, to legislate coordination. I can't, right? I could put it on paper, but like in terms of the implementation, it actually requires the willingness of the other side to pull all those people together and then do the follow-up necessary in all of those various pieces. I mean, there is a desire out there. The whole conversation around lowering the age for CNAs to 16 came up because I have a charter school who wants to start a program to develop folks into that. Interestingly enough, a couple of weeks ago, I had the superintendent for education in front of me. She was talking about the Advanced Technical Career Center that we do. And I was like, oh, great. Do you guys do CNA certification? And that piece hadn't been, like, to your point, we're like all over in the disconnected pieces. And I even find that in the same with, like, I've got a lot of adult education programs in the district who do certification. Like you go for free, go get your certification. If folks don't know about the program, that it exists, all the various pieces. And so I'm hopeful that in sort of the conversation around this legislation, we're elevating some of these issues, but I appreciate all of you being here today. Yes, Judy.
I was just gonna say, I think the one place where this could live is in the deputy mayor of education.
Why education?
Because education is now it's taken on workforce. And it's sort of, I mean, I had this conversation with Deputy Mayor Kine years ago. And it basically came down to the fact that these jobs were not considered good jobs. And so, we've got to get past that and start talking about essential jobs. It's the same conversation we had about early childhood.
Yeah.
Right? And and there needs to be somebody in the leadership role. And I think in the current administration, I think somebody's got to say, we need more of these workers, like, what are we going to do about it? Like and it takes all those pieces.
If I could just tag on to that too, one last thing. I think we need to get over this term good jobs and bad jobs. Anybody who's working a job, that is a good job. And as long as we differentiate, well, your job doesn't make enough money. And in this case, we're seeing that these are essential jobs and they are good jobs because we need them. And if I never hear that phrase by other folks around the city, good jobs and bad jobs, including from the deputy mayor, for education, all the way down, it will be a great, fantastic day. We need to obliterate that phrase.
All right. Well, thank you all so much. We're going to go to the next panel. Well, depending on who's here, I'm going to split it 3 and 3 so that someone doesn't have to be at the table by themselves. Ms. Conley? Great. Lindsay Niles? And Ashidiwat Ayano. I was close. Ayana. Okay, Ms. Conley, when you're ready.
Thank you. My name is Sonia Conley. I've lived in the district for nearly 50 years and worked at HHS and Treasury Department. And among my many issues were long-term care, actually childcare too, and disability. I did a bunch of other things like fishing tax, windfall profits, at any rate. From that experience, I know that this issue goes back 50 years, probably longer. And there are two things I think as an economist, to follow the money. And that's the essential issue. To get more people, we need to have more money, better benefits, and certainly also benefits are important. And the quality of the job, the quality of the supervision, also important. But we really need, and one other issue I guess I would say is allowing Maryland and residents of Maryland and Virginia is essentially raising their wages. Because if you live in, if you commute from Maryland in particular, you can have housing that is less expensive than you would get for comparable housing in the district. So that's important. If Maryland and Virginia are more competitive, then they're taking our workers away. The other issue is that related to a good job. Let's use the term in this. I think this is a good job. Childcare is a good job. In a lot of ways, working with the disabled and elderly who are in some sense disabled is more difficult, more challenging than childcare. Look at with childcare, your child grows and develops. With long-term care, your client is likely to decline and eventually die. And that's a really challenging situation. If you get close to your client, in any event. So I guess I could end by saying, follow the money.
Thank you, Ms. Conley. Ms. Niles?
Good afternoon, Chairperson Henderson. My name is Lindsay Niles, and I'm a managing attorney at Disability Rights DC at University Legal Services. We are the designated protection and advocacy agency for DC residents with disabilities. including residents who rely on life-sustaining Medicaid home health services to age in place. We appreciate the opportunity to testify. The chronic workforce shortages in the long-term care system results in home health services not being staffed by direct care workers, as well as beneficiaries struggling for care and overall survival. DRDC appreciates this committee's leadership in introducing the Direct Care Worker Amendment Act, establishing a new minimum wage for direct care support services at 120% of DC's living wage, and regulatory changes to remedy barriers to worker recruitment and retention. Although this legislation is a huge step in valuing these workers and moving these workers closer to a competitive wage, we continue to urge the district to establish a real living wage for direct care workers, and this legislation should make clear that this wage rate is a floor and not a ceiling. Unfortunately, the district ranked last in the nation on wage competitiveness for this workforce. PHI, a leading authority on direct care workforce, has compiled 24 specific policy strategies for improving direct care job quality and stabilizing the workforce. Those specific recommendations are detailed in my written testimony, including that Medicaid agencies like DCHCF should adequately reimburse providers to allow for wage progression to support a career ladder, and establish policy using a racial, gender, and immigrant equity lens. We understand that DC faces a budgetary shortfall, but investments in this workforce and the long-term care population are not optional. DC has a legal responsibility to address this problem. DC residents have a right to cost-effective, integrated, community-based long-term care in favor of more expensive nursing facility care. DHCF can and must do more to maximize Medicaid funding, the largest payer for long-term care, and to make a significant impact on the size of the workforce. Additionally, we continue to urge DHCF to establish an adequate infrastructure for self-directed care. In DHCF's recent oversight testimony, it claims that CMS will not allow it to amend the EPD waiver to allow for coverage of up to 24 hours a day under Services My Way. As I detail my written testimony, DHCF should determine other ways in which it can offer self-directed services to cover up to 24 hours to lessen these workforce pressures. This would save DC money in the long term because it would help prevent unnecessary and expensive institutionalization due to these service gaps. And also currently in DC, there's approximately 4,000 individuals who are warehoused in nursing facilities in DC, Maryland, and Virginia. And this workforce crisis exacerbates their ability to have their rights followed so they can live in the community like everyone else. As we previously testified, DHCF needs to monitor the extent that EPA beneficiaries are not receiving the PCA services they need due to staffing shortages. This systemic data collection is critical to identify data-driven solutions. DHCF also needs to monitor that the case management function under the EPD waiver is being effectively implemented by DHCF and MCO contracted providers to address gaps in hours and hold providers accountable. Again, we thank the committee for its leadership and appreciate your ongoing efforts to address this crisis. I'm happy to answer any questions. I also wanted to note that we really appreciate the committee's efforts to make this hearing more accessible to people with disabilities. For the first 4 folks that testified, really appreciate that and hope that keeps going. Thank you.
Thank you. Thank you. Ms. Ayana?
Thank you. I want to express my gratitude to the council members for giving me the opportunity to share my testimony. My name is Adisiwet Ayano. I serve as Health and Wellness Director at a retirement community located in Ward 2. That includes independent living, assisted living, memory care units. We have a total of 110 employees and serving 143 residents. My journey in healthcare began about 16 years ago at this same facility I'm working right now as a server. Gradually advancing through different roles, I initially worked as a CNA on the floor, progressed into becoming a licensed practical nurse. Over time, I got my registered nurse degree and became a director of nursing about 9 years ago. Reflecting on my past experiences in nursing, I strongly believe that the role of the CNA is among the crucial and challenging in healthcare, demanding significant mental and physical resilience. During the initial phase of the pandemic, we encountered severe staffing shortage as many employees left their job due to COVID-related fears. I witnessed talented nurses leaving the profession altogether and caregivers opting for careers in IT and other fields. During the pandemic, we were temporarily allowed, as we all know, to hire out-of-state caregivers, which was very helpful. However, the expiration of this authorization after 2 years posed significant challenges, especially for our CNAs from Maryland. The process of transitioning their license to DC, requiring a geriatric nursing assistance or GNA license, was complex and burdensome, involving additional education, financial investment, and exams. The transition disrupted the lives of those who had been with us for years. Even post-pandemic, recruiting qualified nurses and caregivers has remained exceptionally difficult. I have also faced challenges with the reciprocity process, such as with a CNA from Indiana, a Howard student whose license conversion to DC has stalled for over a year. These experiences underscore the ongoing struggles in navigating licensing and staffing issues in healthcare. To address our ongoing staffing challenges, we have been tirelessly recruiting. However, the post-pandemic landscape presents new challenges in attracting and retaining healthcare workers. If we fail to address these healthcare staffing shortages, I fear we struggle to meet growing needs of our aging population. I'm here to express my support for the Direct Care Worker Amendment Act of 2023, which aims to eliminate barriers, bureaucratic difficulties, making it easier to attract healthcare workers to DC healthcare facilities. Thank you. I'm open to any questions.
Thank you. And thank you to this panel of witnesses. Ms. Conley, I feel like there's so much you could teach us about all the things in terms of your experience. And so I appreciate you being here to share your testimony. Ms. Niles, thank you again for your testimony and for always testifying at our hearings to provide some in-depth information. I'm curious, if you had to estimate, how many people would you say are not receiving the required amount of PCA hours in the district right now?
Yeah, because DHCF's not doing systemic analysis of the number of people that are not receiving all authorized home health aid hours, we can't put a very accurate number on the number of people that are not getting their care needs met because of the workforce crisis. But we work with hundreds of individuals with disabilities annually, and many of those folks are challenging denials, terminations, or reductions of their PCA service hours. And the majority of the individuals that we work with, there is some sort of gap in care. There were witnesses that testified previously that particularly the weekend hours are a particular challenge for folks to have their hour staff. But as I mentioned in my written testimony, DC has an obligation to ensure that these folks get reasonably prompt access to timely services. And so this is not optional for them to take accountability and responsibility of this problem to make sure that there's an adequate workforce and also deal with other non-monetary things, right? I talked about making sure they're monitoring to make sure that people's services are being coordinated appropriately so that if there are barriers to care, whether it's staffing shortages or otherwise, that their case managers ensuring that those folks are getting those services.
Okay. Has there ever been an attempt to sort of audit?
So unfortunately, to our knowledge, and DHCF recently reported in their oversight responses that they have not done any systemic analysis of the extent of the gaps in care for this population. So I'm not aware of any current audit of the nature of the gaps on the side in terms of the beneficiary. I know there's been a lot of work around the gaps for the workforce.
Yep.
But there's certainly a need for that audit to occur. And we think DHCF and other DC agencies should be taking responsibility to do that.
All right, we'll follow up on that. Ms. Ayano, I feel like in your testimony, your story, you were the prime example of the workforce pipeline that everybody was talking about. So you went from a server to a CNA to an LPN to RN to the director of nursing.
Yes, that's right.
That's amazing. That truly, it
Thank
is
you.
amazing. But also goes to show, as Neil said, I'm not gonna call it bad job versus a good job, but that this essential job does offer a career ladder, options if people know that that is available to them.
Yes.
Are there other, and did I also hear you did this all at the same,
At the same facility?
yeah,
Mm-hmm.
all at the same facility?
Yes.
That's incredible.
Mhm.
How do we get more like you?
I mean, I want people, to be like me. I always encourage my CNAs to go to school and the nurses to, to continue. I always tell them, what I went through. I was pregnant 3 times in between, these times.
Okay.
And had, 3 babies. So it's doable. Yeah, they can do it.
Yeah. Awesome. All right. Well, thank you. Thank you all so much for being here and for your testimony. Really appreciate it.
Thank you.
All right. Frederica Berkeley, Tarnisha Rogers, and Eric Walcott. Okay. I only see Eric, and I have 4 chairs. So is there anyone who had signed up to testify, but you're on the wrong list, but you're here in person, but we think that you're going to be virtual? No? Everyone good?
That's fine. We can have a conversation.
Okay, I wish I had known. I would have put you on the last panel. All right, Mr. Walcott, when you're ready. Oh, if you could just turn your mic on. There you go.
Greetings, Chairperson Henderson and the members of the Committee on Health. I come before you to give testimony on the proposed Direct Care Worker Amendment Act of 2023. On behalf of the District of Columbia Home Health Association, the Business League, made up of some of the most long-standing home health providers in the District of Columbia. On average, DCHCF providers have been licensed providers for over 15 years. And in the not distant past, when the District of Columbia had great difficulty in attracting businesses to apply to become providers in the home health service industry, DCHCF members answered the call at a great risk and have been viable providers in the District of Columbia ever since. District government payment issues were widespread back then. In fact, we still have some home health agencies who continue to choose not to provide Medicaid waiver services in the District of Columbia because the reimbursement rates are too low. But with the advent of adoptive technologies and the District of Columbia that continues to work more collaboratively with providers, most of the administrative issues impacting the timeliness of payments issues have been mitigated. I must add, however, with the addition of MCOs as a payer of HHA services, we are now facing increasing challenges around payment. The introduction of Direct Care Worker Amendment Act of 2023 is timely and necessary as we navigate through the workforce labor marketplace where there is scarcity of direct care workers. I think it's necessary to highlight the fact that those District of Columbia residents who need assistance with activities of daily living as prescribed by physicians are now waiting longer than ever before to receive care because of our workforce crisis. DCHCF providers have seen a significant reduction in the workforce by individual home health agencies. When surveyed, more than 90% of providers have seen an estimated 25 to 30% drop in available workforce as surveyed in 22 and 23. Additionally, there are fragile, elderly, chronically ill residents going without the full number of hours of care due to the lack of workforce. This is unacceptable because of the right support from the district government. This can be prevented. Hence, I come to make an appeal on behalf of the District of Columbia Home Health Association and all district residents that they serve, that the Department of Health will do all possible to remove existing barriers to attract and retain direct care workers. In the District of Columbia, long-term care workers have long made argument that there is no significant difference between training of certified nursing aides and home health aides. And from a practical standpoint, they deliver the same services, but in different settings. To continue to maintain the distinction between the two, licensing entities is no longer useful and in fact is a barrier to retain and attract a much needed direct care workforce in the District of Columbia. As you may know, the district wage scale for direct care workers was reportedly ranked quite low relative to the rest of the nation. And when you include the acuity level issue, you will see that these direct care workers are heavily underpaid. I will skip through some of this because I want to say that part of the challenges that we have, we need an entity, we need a district official to take responsibility for workforce development. And coming over here, I spoke to a partner from Alabama, and he was sharing with me the dynamism that have been created. Universities have been enlisted, high schools have set up special academies to create a pipeline for workforce. And we need to take that type of effort in the district to resolve the scarcity of the workforce issues that we have in the District of Columbia. I mentioned, as always, overtime. We have to focus on including overtime, or else we cannot meet the current level of need because we lack the workforce in order to provide the services. I want to again thank the council member for taking the lead in setting up this Direct Care Worker Amendment Act, but I think we ought to not stop there. We ought to do more. I will stop there and wait for questions.
Thank you so much, Mr. Walcott. I don't have any specific questions for you because we've had so many conversations about the particulars here. I do just want to say though, one of my regrets is that the district did not act in the fall when we met and we talked about the expiration of the waiver for residents to allow for CNAs and HHAs from Maryland and Virginia to continue to operate here in the district, because I feel like there are some residents who were negatively impacted by that decision. And so that is my regret that we haven't done this sooner.
Chairperson, I just have probably just 2 comments.
Sure.
I've been around the city for the better of 36 years. I know I look quite young, but I first engaged when Congresswoman Eleanor Norton in the freshman year. I was an intern then. I later came on with the Financial Authority and Control Board and helped with the DC Public Schools, came on as a appointed official there, working at the time with Mayor Anthony Williams. I think it is fair to say that we're not seeing the type of dynamism that we saw in government. Government officials are working in silos. We need to create either an intergovernmental agency that can help mitigate those types of silos that we see that exist today. I must say that the folks that we see at the Department of Health and Mr. Aaron Gibson and his wonderful staff, as well as with Deputy Mayor Wayne Turnage, they have the full capacity to do the job. We just need to light some fire somewhere so that there could be a workforce development czar in the District of Columbia to resolve this workforce crisis. If we do so, I think we could all work together with the private sector, with the home long-term care community to resolve this issue. Thank you.
Thank you. Thank you so much for your testimony and for being here today. All right, last chance. Anybody in the room? All good? Okay, great. All right, so we're going to continue with our public witnesses online. Again, for those who are watching virtually, if you haven't done a hearing with us before, you need to affirmatively accept our invitation to become a panelist in order for you to be elevated. So we're going to do panels of 7. Claudia Schlossberg, Jacob McDonald, Sal Savecchio, Veronica Sharp, Caitlin Huck, Andrew Patterson, and Sally White.
Oh, I'm gonna try to get.
All right, we see people coming in. I do see Claudia. So Claudia, why don't you go ahead and get started?
Thank you so much, and good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Claudia Schlossberg, and I chair the DC Coalition on Long-Term Care's Committee on Workforce Development. I'm also noting today that I'm a 45-year resident of Ward 1, a member of the Mount Pleasant Village, and I turn 70 next month. Like other DC residents of my generation, I hope I can look forward to aging in place in my own home, and that today, thanks to your leadership, marks a day when DC moves forward to rebuild a direct care workforce, an essential healthcare workforce that provides core services vital to the health and well-being of thousands of district residents, their families, and our healthcare system. I also want to thank you and your staff, particularly Ona Bacchus and Ashley Strange, for accommodating the ability of homebound residents to participate in this hearing via video and virtual testimony. As you have stated, I don't need to repeat, we face a severe workforce shortage at a time when demand has grown exponentially and will continue to grow for the foreseeable future. I have testified on this issue multiple times, and including noting that last year we lost an astounding 4,489 workers, more than 30% of this workforce. While we need thousands of new direct care workers to meet growing demand, there is only a trickle of new workers in the pipeline, and many of these workers, based on our survey data that we've presented, do not stay long. There's one clear factor that's driving this shortage. Despite the modest increases in pay that DCHCF has instituted based on legislation passed by the council, wages for direct care workers are too low and are not competitive with wages and salaries paid to other workers with comparable jobs. We have noted, and my written testimony includes, for example, a childcare worker who has very comparable credentials and training requirements makes more than $51,000 a year. This bill takes critical steps to break the cycle of historic disinvestment in this largely Black, brown, and immigrant female workforce. It begins to close the wage gap and direct other needed reforms that pose barriers to hiring and retaining direct care workers. I see my time is very short. I want to focus on one issue. We support all the provisions in the bill, but for publicly funded services, this bill raises the minimum wage to 120% of the living wage. This is a good first step. It's probably not high enough, but it's a good first step. But I must sound a note of caution. While raising the minimum wage is critical to improve recruitment of direct care workers, the bill must be clear that this wage rate is a floor and not a ceiling. This is especially important given Director Turnage's written testimony, in which he makes clear that DCHCF views the language in the bill as a wage cap. Again, I have much more in my written testimony, but I'm happy to answer any questions. I will end there. I see my time is up. Thank you.
Thank you. Jake?
Thank you. I'm Jake McDonald, speaking on behalf of PHI in support of the Direct Care Workers Amendment Act. PHI is a national nonprofit, nation's leading authority on the direct care workforce. As you've heard, the district's nearly 14,000 direct care workers are essential to our health, well-being, but also our larger economy. Yet this workforce is in crisis. Between 2012 and 2022, the district added nearly 4,600 direct care workers. That's a 49% increase in 10 years. But it is not enough. We are struggling to recruit and retain enough workers. This shortage is going to get worse due to an aging population, a growing need for services, and poor retention of those workers. Based on U.S. Department of Labor projections, the district needs a plan to find nearly 24,000 direct care workers by 2030. Poor job quality is what's driving this crisis. Median annual earnings are under $39,000, while 38% of these workers live in low-income households, 48% lack affordable housing, and 71% rely on public benefits. Direct care wages are also not very competitive. So our analysis we did at PHI ranked the district last among states for wage competitiveness in the country. Workers can make $5 an hour more at fast food chains or retail stores. This crisis has severe economic consequences. Accordingly, investing in this workforce will create economic gains in at least 4 ways. First, by ensuring better continuity and quality of care, which reduces costly medical services. Second, by saving the costs of recruiting new workers and managing turnover and paying more expensive contract staff. Third, by reducing public assistance costs. And fourth, by cutting the number of people forced to leave their job to care for a loved one. This is often overlooked, but a recent report found that Maine loses a staggering $1 billion of its GDP as people leave the workforce to provide elder care. The quality of direct care jobs is also an equity issue. The district's direct care workforce is 77% female, 96% people of color, and 42% immigrant. Direct care wages must be raised for the district to end its racial and gender wage gaps. PHI believes this bill is a vital step in addressing this crisis because it would take 3 key actions. First, it would set a higher wage floor, assuming changes are made to clarify this as a base wage. Second, it would create a universal credential, making the workforce more versatile and the job more appealing. Third, it would remove barriers to training. In conclusion, we at PHI believe this bill would really make a difference. It is not just a matter of improving the jobs of direct care workers, though that is so important. It is also an investment in the health and well-being of the entire community. By prioritizing the economic security and well-being of these essential workers, we can create an effective long-term care system that benefits all of us. Thank you.
Thank you. Sal?
Good afternoon, Councilmember Henderson. I'm Sal Salvaggio, and I'm a member of the DC Coalition on Long-Term Care and the Northwest Neighbors Village. Thank you for providing this opportunity to provide public testimony and for your support of the Direct Care Worker Amendment Act. Others have testified before you about their personal experiences as recipients of care and the impact that the workforce shortage has had on them and their families. Others have and will testify on the data to support the current and future impact the shortage will have on our DC community. I'd like my testimony to approach the situation by looking at it from a philosophical perspective of what is true, beautiful, and good. The plain truth is that we don't have a sufficient healthcare workforce to care for the needs of folks who require help in their homes, in rehabilitation facilities, and in long-term care institutions. The truth is that we currently don't have sufficient educational pipelines to create that workforce. The truth is that our direct care workers are so poorly paid that when someone is considering entering that difficult occupation, they will often decide to work elsewhere in order to pay their bills and feed their families. Another truth is that our DC government has not yet developed a comprehensive plan to address this problem and create a department dedicated to overseeing such a plan. The beauty, as you have seen in the earlier testimony, are the ways those affected by their healthcare challenges have tried to maintain their dignity, and resolve to live the best they can, and how family and neighbors have stepped to the plate to provide the needed care when a professional healthcare worker is unavailable. The good is being demonstrated right here, right now. I know it is common to denigrate our government and its officials, and certainly this is sometimes deserved, but I have lived long enough to see great things accomplished when our representatives are committed to solve difficult problems. Just think about the effort that was needed to pull off the moon landing or navigate the political labyrinth of passing civil rights legislation. This hearing today is citizen involvement in action, and we may be asking on a local level the equivalent of a moon landing to solve our workforce shortage problem. The DC Coalition on Long-Term Care, our villages, and other stakeholders will continue to press the council and the mayor for meaningful actions to address our direct care workforce crisis. I know that we may sometimes be perceived as being strident and troublesome, but to quote the late great U.S. Representative John Lewis, never ever be afraid to make some noise and get in good trouble, necessary trouble. Thanks again to you, Councilmember Henderson, for holding this hearing, and thanks to your excellent staff for their assistance in making this testimony possible.
Thank you, Sal. Veronica?
Good afternoon, Chairman Henderson, members of the Committee on Health. My name is Veronica Sharp, and I'm the president of the District of Columbia Healthcare Association, which represents all of the district's licensed nursing facilities, several assisted living communities, and the nearly 3,000 district residents to whom they provide care. I want to thank you for introducing this legislation, and on behalf of DCHCA membership, thank you for the opportunity to offer our support. We've heard some very compelling testimony today about how the direct care workforce shortage is impacting district residents, so I'll just summarize my testimony. The Direct Care Workers Amendment Act of 2023 is an important step in addressing the direct care workforce crisis. Recent information from the Department of Labor and also what Jake just testified to shows that long-term care is still below what the pre-pandemic levels for staffing. This bill recognizes the need to attract and retain direct care workers as the district population continues to age and require long-term care services and support. supports. If passed, the bill will create a universal credential for CNAs and HHAs that would allow the trained workforce to work across both settings without having to attend and pay for additional training, which can be difficult with such low wages. The district also requires the administration to review and eliminate barriers to the development and support of on-the-job training and registered apprenticeships that can certify the competency of direct care workers. This is important because DC is not training enough workers to replace those that are leaving for higher paying and less difficult work. And as we've heard multiple times today, we've trained over 4,400 less direct care workers in 2023. As a result of the bill, Maryland and Virginia CNAs will be permitted to work in the district. In a meeting with HRLA this week, the Coalition Workforce Committee learned that they are working on emergency rulemaking to move forward in making this happen. The rulemaking doesn't address exactly what's in the bill because there are some nuances around working with different states, but it is certainly moving us forward in a good path. Finally, the bill establishes a higher wage floor of 120% over the minimum wage, but it's not enough to just raise the minimum wage for these workers. As written, the bill could be interpreted to direct DCHCF to fund to the minimum of 120%, but it doesn't require the agency to fund anything beyond that. The rate methodology of district providers must include a progressive wage scale. The rate methodology has to recognize experience, advanced training, and longevity, or we will see a disincentive for other professionals. Thank you for your leadership and the opportunity to testify. I wish I had a red shirt that I could have worn in support of my colleagues today.
Thank you, Ms. Sharp. Caitlin?
Good afternoon, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to provide a statement in support of the Direct Care Worker Amendment Act of 2023. My name is Caitlin Hauk, and I'm the Executive Director of the Maryland National Capital Home Care Association, or MNCA. Our members are the licensed home care and home support agencies that provide skilled and personal care services to district residents in the environment they call home. These agencies are primary employers of the direct care workforce, meaning the home health aides and certified nursing assistants who provide supportive and hands-on care to those living independently in the community. I will use the term direct care worker interchangeably with caregiver. The majority of MNCA's members provide services in more than one jurisdiction within the DMV. Similarly, caregivers commonly cross jurisdictions and/or care settings to obtain a livable full-time wage. I view the workforce challenges and opportunities we are currently facing as regional. I emphasize regional not only because of our geographic proximity, but because we collectively are a distinct, interconnected healthcare ecosystem. The direct care workforce crisis is a shared challenge that requires collaborative, committed, full-scale problem solving. When I first entered the home care industry from acute care, I consistently heard owners and operators talk about their workforce concerns, particularly those factors that influence job quality. Even 10 years ago, providers were trying to identify effective strategies to attract and retain caregivers. This is because they recognize the essential role that caregivers play in ensuring the health and well-being of district residents, and that many caregivers are purpose-driven in their service because of the relationships that they cultivate through one-on-one care. The direct care workforce crisis reflects a confluence of factors that you have already heard and will continue to hear in greater detail from my industry colleagues and fellow advocates. Ultimately, the workforce crisis impacts care transitions that are being coordinated across our healthcare continuum and the ability of district residents to access the care they need and in the setting they prefer. Significant policy reform and financial investment is needed to address this crisis, and focused, committed collaboration across stakeholders is essential. This is why MNCA supports the Direct Care Workforce Amendment Act of 2023. This bill takes critical steps to close the wage gap by setting a higher wage floor and directs other necessary reforms to mitigate the barriers to hiring and retaining direct care workers in the district. These reforms include creating a universal credential for HHAs and CNAs to unify the workforce under a single recognized certification based on competency, Of note, Maryland is also pursuing a similar legislative initiative for a universal credential. Creating jurisdictional reciprocity to enable Maryland and Virginia caregivers to work in the district. This facilitates a more dynamic and flexible workforce with a greater capacity to meet the growing demand for home care and long-term care services. And removing barriers to training to expand access to skills development and opportunities for career advancement, thereby encouraging more people to enter and remain in this field. Thank you for introducing the Direct Care Worker Amendment Act as a comprehensive, integrative approach to addressing this crisis within our region. Passing this legislation will be an investment in the health and well-being of the entire district community. Thank you.
Thank you. Andrew Patterson?
Yes, good afternoon, Chairperson Henderson. My name is Andrew Patterson. I'm a senior staff attorney in the Public Benefits Unit with Legal Aid DC. Thank you for the opportunity to testify about the Direct Care Worker Amendment Act of 2023. Home health services are a critically important benefit for ensuring that hundreds of DC Medicaid and EPD waiver beneficiaries age in place and stay in their homes, rather than having to move to a long-term care facility. At Legal Aid, we have represented many clients over the years who would absolutely have had to leave their community homes for a nursing facility, but for their home health services, including individuals with dementia, people who are wheelchair bound, and others with conditions that severely impact their functional ability. We most often represent people almost exclusively in the home setting in medical necessity disputes regarding the number of hours they are approved for. But we have increasingly seen people who are not getting the hours that they need, not because of an authorization dispute, but because they are being impacted by the workforce shortage. We thank you for your leadership and appreciate that the council is working toward addressing this workforce crisis. And I just want to highlight several important aspects of the Direct Care Worker Amendment Act, which we support and hope will become law. As others have testified, the Act raises compensation for direct care workers to a minimum of 120% of the federal poverty level. We support this wage increase, and we agree with the many others who have testified that this wage increase must be a floor and not a ceiling for compensating these critically important workers. Wages must be sufficient to make these jobs, which are difficult and stressful, truly attractive to good workers and competitive with other industries. We also support the Act's unification of the credentialing process for direct care workers, which would replace the current process of requiring different licenses for certified nursing assistants and home health aides. And we support allowing direct care workers who are certified and in good standing in Maryland and Virginia to work in the district. As noted, this was allowed during the public health emergency, and in the Long-Term Care Coalition's Direct Care Workforce Survey, multiple providers cited this as a change that would at least begin to help alleviate the workforce shortage. These measures should allow for an increased overall number of workers who are available to provide these critically important services, these critically important home health care services. And if others have very eloquently said, this is a problem that is just going to become ever more challenging as time goes on in the district. And so we appreciate the committee's attention, your attention, and I'm happy to answer any questions that you may have. Thank you.
Thank you. Sally.
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Sally White. I'm a member of the DC Coalition on Long-Term Care and the Coalition's Workforce Committee. I've been an advocate and senior executive in organizations for older adults in the District of Columbia for close to 40 years now. I'm here today in support of the Direct Care Workers Amendment Act and to thank you, Chairperson Henderson, and your fellow council members who co-introduced the bill for taking the issues seriously and putting forth this legislation. As you well know, the Act, if passed into law and funded, accomplishes a number of critical goals to address the incredible crisis we face. I won't go into the details you know so well and have heard from others, except to say that from where we are now to where this passed and funded legislation will take us is tremendous, and yet we must ask for changes before we even get started. As you have heard from others, 120% of the living wage is a significant increase in the minimum wage for direct care workers, but to keep staff in these positions and attract the thousands more needed, we must fund these jobs as careers or workers will continue to flee the profession. As you intended, the 120% must be the floor, not the ceiling. We ask that the act be amended to include higher amounts for advanced certification and years of experience to avoid what Director Turnage describes in his testimony, the possibility that the pay for some staff would decrease if this 120% is the floor and the ceiling. Secondly, I wanted to point out that language in the bill around the 16-year-old high school students being able to pursue the direct care worker training and employment be changed so that it includes high school students, not just those working on a JED. There is no need for this separation, and indeed it was likely not intended when written, but we need to ensure that these are good jobs for 16-year-olds and older, no matter whether they start their training while in high school or while working on a JED. You've heard from many individuals and organizations today about the full-blown crisis enveloping older DC residents who need care and the organizations that are trying to help them. The Direct Care Worker Amendment Act of 2023 must be made into law and adequately funded if we have any hope for the future of our older residents and their families. Thank you.
Thank you. Thank you so much to this panel of witnesses for your testimony. Ms. White, I'll start with you just for clarification. So the CNA 16H portion that was in the direct care worker bill, I think it was just a drafting error on our front. We were not intending to leave out regular high school students. But that actual portion of this bill is going to be in another bill that we are, the committee is marking up next week. So we're just going to put that into the HORA.
Great. Okay.
Health Occupation Revision Amendment Act, for those who are listening who don't know what the HORA stands for. That was a proposal from DC Health to include it in the HORA, and that actually will allow for the programs who wanted, like I said, there was a school who wanted to start the CNA program. By including in the HORA, that would allow for them to start in the fall of school year 24-25. So that's great. I also think what you said, we need to fund these jobs as careers, I think was an important piece to keep in mind there. Okay, there was a lot to cover in this particular piece. I wanted, Mr. McDonald, if you're still here.
Hi, Chair Henderson. I am. Sorry, I've had some internet difficulties, which is why my camera's off.
No problem. So PHI was the one who did the study that ranked DC last in wage competitiveness in this area?
Yes.
Okay, how many other jurisdictions were a part of that?
Every state, so 51 in total.
Oh, okay. So we were last. Okay, great. Who was first by chance?
Boy, I'll look that up for you and get back to you before your time's up here.
Okay, great. You know, what would be better if you could forward us a copy of that study or a link to it?
Absolutely. It's cited in my written testimony, including a hyperlink to the study.
Okay,
but I can
all right.
follow up with that.
Great. Thank you so much. Ms. Schlossberg, I wanted to ask if the coalition had discussed the appropriate numbers for a tiered progressive scale.
We've had some internal discussion and in fact, with Mr. Paragol and some of the other providers in terms of trying to look at what that could look like. We've modeled it several different ways, including using the current differentials that exist in Medicaid today with the 117.6% with the higher wage rate being I'm trying to remember like 134%. I'm not exactly remembering, but we use the same ranges to see what that could look like. But we've also used some different ranges. So we have tried to look at that issue.
Okay.
We're happy to share, you know, what we've done with the committee. We'd be happy to do that.
Okay. That'll be interesting. we're in this conversation with early childhood workers around a progressive scale as well. It's difficult. I'm not even gonna lie. It's very difficult to do a progressive wage scale that's tiered, that not only encompasses credentials, but also experience and get it right. So I don't want anyone to think that because I'm asking Claudia these questions, that's something we're gonna put in this bill, but is something we'd certainly want to explore further.
If I might just add something, you
Sure.
know, some of this is dependent on how DHCF sets rates for different provider types and how often they rebase or relook at those rates. For example, and I've been authorized to say this, Edenbridge Health is a new PACE provider. They provide home care as part of the package of services, but they are paid on a capitated basis. So they get a rate that's based on an actuarial analysis of costs, and they have a lot of flexibility within that rate. So they've been able to raise the starting wage of their home care workers to no less than $21 an hour. They are not having a problem recruiting home health care aides. So some of this has to do with the way we pay. Home care agencies, for example, are bill in 15-minute increments. You know, and there's a rate set for that. So there's a lot of complexity here, but as you've heard, one of the things we'd like to see is more creative thinking about how to address this problem. But at the bottom line is providers need to be paid for their full labor costs, because labor costs have gone up across multiple sectors. The private sector raised rates after the pandemic. We saw a little bit of a bump for these direct care workers, but not enough to be competitive with these other jobs.
Definitely hear you there. So thank you for that. And we'll certainly follow up. Ms. Huck, Caitlin, you mentioned in your testimony that Maryland is pursuing similar legislation for unified credential. What are they calling their credential?
I think they're still finalizing that. I'm happy to verify the terminology with our lobbyist, but that hasn't been finalized just yet.
Okay. I try to do some, given that we work in a region, it's always helpful if everybody's working from the same terminology or the same grid of titles. So that would just be really helpful for us to kind of know. Especially as we think about more types of possibilities around reciprocity. Obviously, we're going to do that in this bill, but we try to streamline it as much as possible in the future. But thank you so much to this panel of witnesses. Again, if you haven't submitted your written testimony for the record, you can upload it on the DC Council website. And I hope that you all do that, because I'm sure some of you had longer written testimony than what you presented today. So thank you all. We're going to go to the next panel. Keisha Childs, Crystal Scott, Makita Vanderpee, Rajan Thomas, Carmen Dillard, Tarnisha Rogers, Alexa Poteet. We will give it a minute. Again, for folks who haven't done testimony with us before, you have to affirmatively accept our invitation to become a panelist. Okay, I see Miss Childs. Whenever you're ready, Miss Childs. You're on mute, Miss Childs.
Okay.
There you go.
First of all, I would like to thank you for allowing me to share my testimony. My name is Keisha Childs. I'm 45 years old and I am a CNA. I've been a CNA since I was 16 years old, and it's hard for us. We supposed to be heroes when the pandemic was there, but some of us worked 2 jobs just to survive. I've been living in Ward 8 for 98% of my life, and I can barely afford to live in Washington, D.C. any longer. Sometimes I've worked 16-hour shifts. Sometimes I done did it doubles 4 to 5 days out of a week because I'm trying to take care of my family. I feel as though that is no different as a CNA or a HHA worker. We are one and the same. We do the same jobs. I don't feel like we're different. I also feel as though that we should be able to work in Virginia, Maryland, and DC, no matter what, because if we was good enough to work there during the pandemic, then what's the difference? I feel as though that is really no difference at all. Sometimes that I myself have left being a CNA, a caregiver, because of the pay. You know, I have 2 children that I have to take care of. And when I'm not getting adequate amount of wages at here, I have to go somewhere else so I can be able to take care of my family. Sometimes we show up is because we actually really do care. We don't show up because of the money, because to be honest, I feel like we do the hardest work and we get the lowest pay. And we definitely need this pay for our family. We take care of y'all family. We take care of people that we don't know at all. And we get the lowest pay. We are there when they are sick, when they're in health, at their last moments. They become our family. And I feel as though that sometimes you have to think about who's going to be there for you in your time of need or your family time of need when you're going to need somebody or somebody in your family going to need, because we are leaving because we, like the person said before us, sometimes you can work at McDonald's and get a little bit more money. And we have to take care of our families ourselves. So I hope that this amendment passes. I hope that y'all take real consideration to it. I appreciate you for your time. Only thing I can say, the last thing I'm gonna say is that my job where I'm at Forest Hills of BC has helped me with the opportunity, because I was started off as a CNA, and I'm a central supply worker that I make a little bit more money, and well as I'm getting the opportunity to go to UDC so I can be a registered nurse. I'm one of the lucky ones, but I still have to think about my fellow CNA workers. So thank you for the opportunity.
Thank you for being here for your testimony. Ms. Scott? Ms. Scott, you're on mute.
That would help. Thank you. Good afternoon, Council Member Henderson and members on the Committee on Health. My name is Crystal Scott, and I'm submitting testimony today as the licensed nursing home administrator of Forest Hills of DC. Forest Hills is the oldest private, not-for-profit organization with a tradition of excellence since 1889. Our services include long-term care, skilled nursing, and assisted living. I'm here today to express my strong support for the direct care worker wage increase and initiative to increase the pool of skilled direct care workers. I ask, who will take care of our aging population? As someone who has been in the healthcare sector for more than 30 years, I've witnessed firsthand the critical role of the certified nursing assistant, CNA, and the high quality care they provide to our elderly population. As an administrator deeply invested in the welfare of our community and the quality of care provided to our most vulnerable populations, I can attest to the urgent need for such measures. The projected growth in the number of adults aged 65 and older is alarming. From 2030 to 2060, the number of adults in the U.S. who are 65 years and older will increase from 56 million to 94 million. Additionally, the number of adults aged 85 and older is expected to triple from 6 million to 19 million. This rapid growth in the elderly population and the loss of more than 4,400 direct care workers in long-term care in the district highlights the urgent need for equitable and adequately compensated direct care workforce. Over the past decade, increases in wages were due to local and federal funding as well as COVID-19 stimulus measures. However, this wage growth has slowed down dramatically, and I'm concerned about the long-term sustainability of our workforce. In recent years, our organization has adopted a growth mindset and embraced creative solutions to address the challenges facing our workforce. We work with local and federal agencies to combat our workforce crisis. We pioneered the first certified nursing assistant apprenticeship program in long-term care sector in the Washington, D.C. area. This innovative program has not only provided career pathway opportunities, but has also significantly contributed to the recruitment and retention efforts of our CNAs within our facilities. In our moments of workforce crisis during the public health emergencies, CNAs from Maryland and Virginia were allowed to cross the DC line to work in our DC facilities. Despite these efforts, we continue to face challenges in the progressively competitive labor market. And speaking with nursing assistants, they feel their wages are stagnant and do not reflect the contribution they make each day in providing quality and safe care to the residents they serve. As a result, many dedicated individuals are compelled to leave healthcare to find more attractive job opportunities in other fields, thus contributing to a shrinking healthcare workforce. In closing, we must recognize the importance of investing in our direct care workforce, finding the resources to do so without passing the cost on to the provider. Thank you, Council Member, for bringing the Direct Care Amendment Act 2023 to the forefront in your time. Thank you for making a difference.
Thank you, Ms. Scott. Makita?
Good afternoon, Chairperson Henderson, and thank you for the opportunity to testify today with all of my like-minded colleagues here. My name is Makita Vanderpoy, and I'm the Executive Director of Leading Age DC. We're an association representing mission-driven, largely nonprofit organizations serving older adults across the district, including nursing homes, assisted living, affordable housing, senior villages, home and community-based services, and life plan communities. I am testifying to express Leading Age DC's support for the Direct Care Worker Amendment Act of 2023. I commend Chairperson Henderson and the 7 co-sponsors of this groundbreaking bill addressing the direct care workforce crisis, and thank you for your leadership. The Leading Age DC provider members who have collectively served many thousands of older adults in our community across hundreds of years collectively applaud this effort to support and rebuild the essential healthcare workforce and remain committed to providing high-quality care to some of our most vulnerable residents. If enacted, this act has the potential to enrich the lives not only of direct care workers, but also of our elders and the community at large. The necessity of this legislation is highlighted by the rapidly growing population of older adults in this district. It is especially troubling then that the professional caregivers who make it possible for family members to work in a fulfilling profession and for elders to be cared for and to age with dignity are leaving the field for jobs that are less difficult, require less training, and pay more money. The 5th annual Direct Care Workforce Survey, released by the DC Coalition of Long-Term Care Providers, of which I'm a member of the Workforce Committee, represents a continuation of the alarming upward trend of persistently high turnover rates and difficulty hiring new workers experienced by providers who are unable to pay competitive wages due to inadequate reimbursement rates. The wage increase proposed in the Act, guaranteeing direct care workers a minimum wage of no less than 120% of the district's general minimum wage, is a positive step towards providing a living wage. You've heard from other witnesses that the bill as currently written does not go far enough to recognize the value of this critical workforce. I encourage the committee to include language to ensure that providers are fully reimbursed for their labor costs so that workers are able to see their earning power grow with experience. Fair compensation for this workforce, which is overwhelmingly represented by women of color and immigrants, is in alignment with the mayor's priority to provide a fair shot to district residents faced with rising costs of living, stagnant wages, and structural inequity. I have much more in my written testimony, but I'll close here to say that while I recognize that finding or creating revenue to fund needed pay increases and workforce training is challenging, this is an investment in the health of our residents that we cannot afford to overlook. Direct care workers deserve a living wage. Older adults need access to timely quality care, and young people and those looking for a career change should see professional caregiving as a fulfilling career with potential for wage growth and professional advancement. Our elders have so much to contribute to communities, and the Leading Age DC members are committed to providing the high quality care that they need. To do so, they need your continued support and a coordinated all-of-government approach to finding long-term solutions for this workforce crisis. Thank you for your time, and I welcome any questions.
Thank you. Mr. Thomas?
Good afternoon, Chairperson Henderson and the members of the committee. First of all, I want to say that the district, we've been working in the district and for district residents for over 33 years, and I'm proud to be part of this group that provides care to our elderly folks in the district. And testimony has been given with statistics and analysis, and so I will not belabor those points, but I do want to commend you, Chairperson, and the sponsors, co-sponsors of this Workforce Amendment Act to move forward, and I support the proposed legislation. As was mentioned, there are some tweaks that some folks have suggested, and I would certainly welcome those as well. The reimbursement rate, as you may know, for home care agencies are specifically based upon how many hours of service are provided. And there is no room, say, for going over cost and still being viable, unlike some facility-based providers. So I think it's very important that the rate be established and as mentioned as a floor, so that we as providers can continue to make sure that we remain viable to provide the quality of care that our elders so much deserve. In addition to some of these wage rate issues, I would suggest that I have a couple of other suggestions. One that our direct care workers face constantly. As you know, they are and I would speak specifically to the home health aides, and they are required to be licensed by the Department of Health. In addition, as most of our clients are in fact Medicaid beneficiaries, these home care workers also need to be enrolled as DC Medicaid healthcare providers, another step. Now, this is sometimes a complicating factor for them because they also have to now apply, make another type of application, and upload their licenses. So as was pointed out before in other areas, coordination between various and across agencies would be very helpful so that it could just be a one-step process. Also, I'd encourage the expansion of the facilities for training requirements. And I would suggest one item is that the testing standards for training schools have been very stringent. And many who are qualified lose their place of education because others are not able to pass. I see that I'm over time, but I will certainly submit my written testimony to the committee. And thank you for your time. And I'm here to answer any further questions. Thank you very much.
Thank you, Mr. Thomas. Carmen? Okay. Tarnisha? Okay, I do see Alexa.
Good afternoon, Chairperson Henderson. Thank you for having me. My name is Alexa Poteet, and I'm a clinical social work graduate student at the Catholic University of America and the mother of a child with a disability. I'll be brief for everyone. I wanted to voice my testimony in support of the Direct Care Worker Amendment Act to help address the shortage of skilled helping professionals available for direct care. This shortage affects families deeply, and greater access is needed. Caregiver burden is enormous. Removing licensing difficulties is a first step in increasing access for this vulnerable and marginalized population. Thanks for having me.
Thank you. Thank you so much to this panel of witnesses for your testimony. I do have one follow-up question for Ms. Scott.
Yes.
Ms. Scott, are you all finding in terms of there's one position sort of in this direct care worker space that is more difficult to recruit for than others?
I believe, as someone indicated earlier, just across the board, recruitment for anyone in the healthcare sector, it has been challenging for us as a facility in the district. But we do find that the most compelling challenge has been the certified nurse assistants that we utilize here at Forest Hills of DC.
Okay. And my other question, just in terms of the change that we're making in the HORA, but do you have any concerns about 16-year-olds working in your facility?
I don't, because I'm a product of a New York school system in which I was 16, 17, and been involved in a vocational high school in which, when I graduated, I was able to take the boards as a licensed practical nurse. So I do support having the programs in the charter schools or in the district schools.
You sound like my mom, who is also a product of New York Public Schools. She went to Claire Barton, and so also
that's where I went.
You went to Claire Barton too. See,
Yes, I
I'm
did.
trying to tell these folks in DC there is a model in terms of our workforce issue.
Yes.
These other jurisdictions have been able to figure it out, and I don't understand how we have not been able to do so here. But give it time. We're going to get there. Nonetheless, thank you so much for your testimony. Thank you to all of the witnesses on this panel. We're going to go over to our next panel. Lori Lopez, Natasha Curtis, Winifred Santos, Tanya Robinson, Quanika Jackson, Nanina Pinnell, and Jabron Eubanks. Okay, just again, for a reminder for folks, you have to affirmatively accept our invitation to become a panelist if you're going to join us. There we go. We've got some folks coming in now. Okay, Ms. Lopez. Okay, Ms. Curtis. Ms. Santos. Ms. Robinson. Ms. Jackson. Ms. Pinnell. I see your box. Nanina Pinnell. If you're speaking, you're on mute. Okay, we'll come back. I do see Jabron. He's ready.
Yes, good afternoon. Yes, these are actually a couple of my members who may be having some technical difficulties. So if we could, I just spoke with Tarnisha. If we could circle back to her, I think she missed the accept invite, and I just text Nina as well as to make sure she's unmuting once it's her time. But yes, thank you for having me. And I am yes, I'm Jabron Eubanks. I am the political organizer with 1199 SEIU. We represent over 400,000 workers across the healthcare continuum. And I'm here representing healthcare workers who are struggling to make ends meet on low wages and are unable to provide the critical care for patients due to severe staffing shortages. So we understand direct care workforce is in a crisis, but I'm a little hesitant to use the word crisis because I feel like the impact has diminished. We've exhausted that language since nursing homes became the epicenter of COVID-19 pandemic over 4 years ago. And that pandemic has highlighted the brokenness of our long-term care system, and these workers who are once called essential are feeling more burned out and underappreciated than ever. I'll spare you some of the numbers as some of my partners with the DC Long-Term Care Coalition, spoke on the aging population continue to grow and the certifications are down. So I just want to speak a little bit about the aspect of my job that really drives me the most, which is fighting for better wages for our workers, solely because of the stories that I hear. When I speak to our members, their number one concern is always for the patients. When I ask about what their toughest challenge is, it's knowing that they can't provide high quality care to residents due to being short-staffed and overburdened. When I ask about wages, they just want to be able to pay for mouthpieces for their cleats for their grandson's Pee Wee football league, right? These are genuinely good people with huge hearts who are fighting for very basic necessities. Yet every day they get up. Some take 2 buses, a train, and an Uber to show up for their patient, because a lot of times the worker is all the patient has. This work is mentally draining and physically demanding, but they do it because they care. They're caring for our elders and in times where we can't care for them ourselves. When I speak to some of our members, they're actually paying out of pocket for cleaning supplies, for just basic necessities that they need to get through their job. And we understand that this is not just a workforce crisis, but as we mentioned, it's an equity crisis, right? Over 87% of direct care service workers in a region are people of color, and most of the workforce is constitute of Black women. And 1 in 5 direct service workers in DC live in poverty, and 63% rely on public assistance. I come from a family who needed a home health care home health aide while my uncle was a politician and my aunt was at home sick. Our home health aide was a lot more than just a worker, but she became family to us. And I understand that families like mine depend on us to center the needs of our elderly and disabled residents. So thank you again for your time, and I have a lot more in our written statements, and we'll be providing some from our members as well. Thank you.
Thank you, Mr. Eubanks. I do see Ms. Rogers.
Hello, how you doing? Can you hear me?
Yes, ma'am.
My name is Tarnisha Rogers, and I've been working as a CNA home health aide in DC for the last 17 years. It's a good job, but the pay is low. I often have to work 2 jobs to support my family. The work we do is very strenuous on our bodies, as we work short of employees and pick up shifts, all while caring for the city's loved ones, which is surprising that we don't get paid more money. On top of that, some jobs don't offer adequate insurance to keep us healthy to do our jobs. Recently, I had to recertify for my CNA and home health aide certification. I recertified as a CNA, but was unable to do my recertification as my home health aide because I didn't have adequate in-services completed, even though I worked the last 2 years. Unfortunately, that has limited my scope of employment and prospects to work. If I could speak for all who are not here, please pass this direct care workers amendment. Don't let companies in DC low pay, hardworking caretakers. Thank you.
Thank you, Ms. Rogers. Ms. Pennell? Ms. Pennell, you're on mute.
Hello.
Hi, how are you?
Fine, and you? I'm going to read from my transcript because I'm literally driving home. The cost of living went up, and the cost of food, the cost of everything literally went up. The residents are frustrated. They are fighting. They fight the nurses. They curse. They beat on us physically and mentally. Abuse the CNAs. Abuse the CNAs, other parts of the nursing team, which causes our jobs to be more complicated, complicated working short staff while doing 3 different jobs for one person's pay. Some CNAs like myself purchase our own supplies such as soap, lotion, deodorant, etc., including cleaning supplies to clean the residents' rooms with all in. While doing those things, we are being poorly compensated. We're suffering mentally and physically undue hardship to the fact that we are not getting paid a fair wage or receiving starting pay at 17, which is very discouraging. We are going above and beyond our duties to be treated so poorly. Also, being a CNA has become overwhelming and stressful. This also gives you anxiety, also makes you miserable. I want to quit, but my family is so proud of me and I don't want to let them down. The job is making me miserable. And also, do you know that CNAs and nursing staff are high suicidal rates? My statement is complete.
Thank you. Thank you so much for your testimony and for being here. I know that you're trying to juggle multiple things, so I really appreciate that. Ms. Rogers, I wanted to ask you a follow-up. You mentioned that you recently had to renew your certification for both CNA and for home health aide, but
Yes.
for one of them, they said you didn't have enough hours even though you had worked. Can you say more about that?
Well, you have to have in-service hours. I had my CNA in-service hours, but it's different from home health aide in-service hours. So you have to do these in-service hours every 2 years and make sure you have enough, with usually 12 to 24, and to recertify for both.
Right, but as we
Some
sort of
in-services are different in the facility than the ones when you go to people's houses. So.
Oh, I see. Okay. So for you to have the certification in both, you would have to have done in-service hours, well, essentially double what everyone else to do both sides. But having a unified credential, you would only have to do in-service hours one time.
Yes, and I used to be a CNA. I was first a CNA when I was 22 years old in Norfolk, Virginia, and we didn't have to have that then. So I would be glad to go back to that,
Okay. Why did you decide to do the second certification?
Because I wanted to open up my scope of more employment, so I could have options.
That makes sense. Okay. We all need options, and I think your testimony sort of illustrates even more around the impact of streamlining this credential, what it could mean for folks in the profession, in the workforce.
Yeah.
All right. Well, I don't have any further questions for you all for this panel. Thank you so much for being here and taking time out of your schedules to join us. I really appreciate that. We're going to move to our last panel of public witnesses. Just to telegraph for people for where we're going to go, we're going to do this last panel of public witnesses. We're going to take a 5-minute break. And then when we come back, we'll do the government witness testimony. Fesha Mulligan, Andrea Brown, Bankole Viatonu, Zenobia Barnes, Carrie O'Reilly, Nikika Elkoi. Apologies in advance. I got the names incorrectly, but again, you do have to affirmatively accept our invitation to join. So give it a minute while we transition. Okay. I don't see Fesha. Audrey Brown. Okay. Bankole. Great. When you're ready.
Hello. Yeah, good afternoon, Council Member Henderson and every other panels. My name is Bankole Viatono. I'm the Human Resources Director with Linex Services. I'm here to support the Direct Care Worker Amendment. Direct care workers are unsung heroes of the healthcare, tirelessly dedicating themselves to the well-being of those they care for. Their commitment is unwavering, often going beyond the call of duty to ensure comfort and compassionate. They are skilled professionals who navigate the complexity of healthcare with great empathy, making a profound difference in the lives of the patient and the families, the families. Their work is not just a job, it's a calling that they all answer with resilience and kindness, embodying the very essential of humanity. I have been opportune to meet, firsthand employees and also speak with the DC resident that we provide the services to. During this period of the pandemic, we have experienced a huge shortage of workers. A lot of my employees have actually left the field because of commute, not being able to travel the distance they have to travel from Maryland down to DC, trying to keep two jobs to meet up with their financial obligations and care for the family. This has continuously been a very big challenge for us, that we continue to hire and try to reach out to the residents. Also, the residents have reached out to us to tell us how much they need the services to keep up with their daily lives. I've had few residents that have lost their jobs just because they don't have an home health aide come to their home to care for their children. And for the record, we are a pediatric agency. We work with kids with special needs. We know what it entails to be with those kids and with the services their parents need for them. So I'm so glad that this has come up, and this is a good hearing for the amendment for home care services to be looked upon and see the essential and what this industry, what this group of health workers does for the industry. We're really looking forward to see where it is more addressed, tailored, and keeping the competency of every professional there. So I furthermore say direct workers frequently encounter financial difficulties due to the low compensation, minimal benefits, and minimal opportunities for them to sometimes up their career advancement. These issues not only affect the workers' quality of life, but the quality of life they can provide for their family. It is imperative that we address these challenges to ensure both the well-being of direct care workers and the individuals they serve. I could talk on and on, but I think this is where I would put a hold, because I have stories of families reaching out and sharing the difficulties they get. Thank you.
Thank you. Zenobia?
Yes. Good evening. Good afternoon, Council Member Henderson and everyone on the panel. Can you hear me?
If you could just speak up just a little bit.
Okay. So, good morning, Council Member. My name is Zenobia Barnes. I'm here from Health Management, Inc. I just wanted to address a few points about the Direct Care Workers Act, and I think it's a good idea, and I do support it. We really have difficulty recruiting direct care workers because of the pay, and we also we've also had CNAs come to try to apply, but they're no longer eligible to work in the District of Columbia without a license, a HHA license. So that was another obstacle that's causing us a great shortage. We've had tremendous amount of PCAs leave the healthcare field because of the pay. And I really hope we can decide for the healthcare Direct Care Workers Act to support our home health aides and hopefully CNAs that can work in the District of Columbia so that we can increase the workflow for our patients and our clients in the District of Columbia. Thank you.
Thank you. Ms. O'Reilly? Nakia? Ms. Iloike, I see your a box. If you're speaking, you're on mute. There you are. You're still on mute.
Can you hear me now?
Yes.
Okay. Good afternoon, the chairperson and members of the council. It's an honor to speak to support this bill, the Direct Care Worker Amendment Act of 2023. I'm a DC resident. I live in Ward 4. I'm a home care agency owner, and I'm a pediatric certified nurse, and our agency is pediatrics and special need. And I'm glad that this is coming up because the shortage of staff has a lot of impact on the families we service. Like the mother, Alexia, the one that testified, you see, she's a student and she has a special need child. So when the service is not there, it's so much a burden to them. Some of them will not do well in school. Some of them will lose their job. So whatever needs to be done to improve this personal care, direct care workers, please, we are so in support of it. One of them is the payments. If the payment is increased, that would be nice because that will keep them in the job. We lost a lot of staff that went into IT because that one pays more, less risk because they are staying in the home and doing the work, as opposed to these people going in the patient home, facing through so many challenges. Some of the staff will go, their car will be towed, they will be getting ticket of $240, but because of the love they have for their patient, these children, they keep going. Also, if the training can be extended to the 16 years, the high schoolers, that would be nice because they are full of energies and the type of children we take care of need, young people that will be able to keep up with their activities. So that is very, very important if that can be allowed to happen. And also streamlining the training. The pandemic allowance that we were able to use the Maryland and Virginia CNA was so much a help in helping to take care of the lapses and the shortages. So we are supporting that if it can be reopened and the training be streamlined, like one of the testifiers, you see the suffering that she was going through. Being in an institution, CNA, you have a different renewal requirement, and for her to get the HHA, another renewal requirement. But if it is streamlined, just that one in-service will take care of both of them, and she can work in the institution and work in the home. So we are so much in support of this, and that will help a long way in curbing the problem. Thank you so much.
Thank you. I think we've been joined by Mr. Mulligan.
Yes, good afternoon. Councilmember. First, I want to thank the DC Council for allowing me to testify and support the passage of the Direct Care Worker Amendment Act of 2023. Second, I'd like also to thank Honorable Council Member Henderson and other members of the Committee on Health for introducing the legislation and the chairman for referring it to the Committee on Health. Thank you for all supporting this critical legislation. We believe it will help us deliver quality services to the residents of the District of Columbia. Honorable Council members, my name is Fasaha Mulalini, and I'm the past president of the District of Columbia Home Health Association and Chief Executive Officer of Brahan Home Care Agency, which had been providing quality service for more than 23 years to the residents of the District of Columbia with unwavering dedication and commitment. Our commitment to providing quality, cost-effective, sustainable service has withstood the test of time, especially during the COVID-19 challenging times when our staff delivered above and beyond the call of duty every day. Primarily, the reason I support the legislation is threefold. First, to some extent, it alleviates the critical shortage of healthcare workers by providing the workforce with a minimum salary equal to or greater than 120% of the district living salary. Supported by Medicaid and DCAL, it also supports streamlining direct care workers' certification and competence assessment process. We believe this is a paramount to ensure the recruitment and retention of home health workers. Second, it creates a single, all-encompassing certification for direct care workers that incorporates the skills of certified nursing assistants and home health aides. It also allows accredited nursing assistants and home health aides from Maryland and Virginia to work in the District of Columbia. Third, it requests the mayor to look into and remove any obstacles such as programs that help people learn on the job and officially recognize apprenticeships. Honorable Council members, talking about obstacles, I'd like to take this opportunity to highlight the need for a guide from the Council to standardize and streamline survey and competency audits. We believe such compliance audits serve as an accountability tool to ensure the delivery of quality service and learning process to increase the quality of services. To this end, we need to standardize, streamline, coordinate, consistent, predictable, valid, reliable, and practical, timely survey and compliance audits. For example, we believe DCHCF audit process requires alignment. Service My Way beneficiaries receive less DCHCF scrutiny. In contrast, state Medicaid provider organizations that provide home health service are heavily regulated, indirectly affecting HHA that prohibit workforce entry. Another example is the Paperwork Reduction Act of 1980, which requires agencies to perform their information activities efficiently, effectively, and economically. However, currently, providers must maintain electronic visit verification data and paper timesheets simultaneously for home health aid services. Sendata provides EVV, the software, but does not have all the components required by DOH, and agencies are getting citation and recoupment. The aforementioned obstacles discourage potential home health aides from entering the field in favor of ready-made alternatives from the gig economy, like Uber, Lyft, Target, and higher-paying retail stores like Walmart. Finally, honorable council members, I want to thank DOH and HRLA DHCF for their support and partnership in helping us deliver quality home care service to the elderly and persons with disability in DC residents. Thank you for allowing me to testify to support the proposed legislation and for listening to and considering the issues I raised. And I look forward to answering any questions regarding my testimony and the issues I raised. I welcome any questions you may have. I thank you very much.
Thank you. And thank you to this panel of witnesses who testified. Ms. Uwike, I want to say thank you so much. I think that sometimes when we talk about the direct care worker space, a lot of people assume that the clients are all adults or elderly. And I think you illustrate that there are pediatric clients as well who have PCA services, and the impacts on family in terms of their ability to do job or school is also critical and important as well. I don't have any specific questions for this panel. I want to say thank you again. I want to thank all the public witnesses who testified. And again, ask that if you haven't submitted your witness testimony for the record, if you could please go to the DC Council website and do that now. As I telegraphed before, we're going to take a 5-minute break. And then when we come back, we'll hear from Wayne Turnage, who's the director of the Department of Healthcare Finance, and from Dr. Teresa Walsh, who is the executive director of the Board of Nursing. So we are in recess.
Thank you.
Okay, and we're back. We'll have our government witnesses. We have Wayne Turnage, who's the Deputy Mayor for Health and Human Services, as well as the Director of the Department of Healthcare Finance, and Dr. Teresa Walsh, who is the Executive Director of the DC Board of Nursing at the Department of Health. They're joined at the table by Melissa Bird, who's the head of Medicaid, as well as other members from Department of Healthcare Finance. Before you begin, I need to swear you in. So you and all the people who might be speaking. Yes, there we go. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
Awesome. Okay. Director Turnage, is it okay if Dr. Walsh goes first?
Sure.
Wonderful.
Thank you. Good afternoon, Chairperson Henderson, members of the Committee of Health and staff. My name is Dr. Teresa Walsh, and I'm the Executive Director of the District of Columbia's Board of Nursing within DC Health's Office of Professional Licensing. On behalf of Dr. Ayanna Bennett, Director of DC Health, I'm pleased to appear before you to provide testimony today on the Direct Care Worker Amendment Act 2023. We appreciate the committee's focus on the district's nursing workforce, but have concerns that the approach will be outlined in this legislation will not address the underlying issues in the nursing profession. Instead, we would welcome a larger conversation about the state of the healthcare workforce with policy solutions so that we can bring more qualified individuals into the workforce while supporting them in climbing their professional ladder. The nursing profession is a central pillar of our healthcare system, and those professionals are often these individuals who work most closely with patients. Nursing professions include certified nursing aides, CNAs, or home health aides, HHAs, who are assisting older adults in their daily healthy living needs, registered nurses supporting life-saving surgery, or certified nurse midwives delivering newborn babies. In addition to serving these different settings, nurses also make up the largest portion and diversest type of professionals within the healthcare workforce. Despite this large workforce, the nursing workforce itself is facing challenges both nationally and within the district in meeting the needs of the patients. Nationally, 1 in 5 RNs will leave the healthcare workforce in the coming years, due in part to the emotional and physical fatigue from both the pandemic and the overall healthcare professional workforce shortage. For nursing professionals in the long-term care setting, the situation is even more dire. The Health Resources and Services Administration, HRSA, estimates that there will be a 44% increase in the demand for nursing assistants in long-term care settings between 2021 and 2036. This demand is unlikely to be met as the number of nursing assistants is shrinking. Within the district, a similar workforce challenge exists as we experience a shortage of HHAs and CNAs, collectively known as nursing assistant personnel, NAPs, we call them. NAPs work in many different settings, including long-term care facilities, the homes of older adults, people with disabilities, assisted living facilities, and hospitals. They often support some of the most vulnerable patients within the healthcare system and work diligently to enhance patients' overall quality of life. HHAs receive training that focuses on maintaining a safe home so the patient can primarily be supported as senior citizens and people with disabilities to maintain their quality of life in their residence. While the CNAs receive similar training to the HHAs, CNAs work and focuses on long-term care and acute care facilities. As of March 2024, there were 2,959 CNAs, 7,121 HHAs certified within the district. We have seen an overall decrease of 18% in the number of certified NAPs between 2020 and 2024, with the certified HHAs decreasing 13% and CNAs decreasing by 28%. This decrease is concerning to DC Health, and we appreciate the Committee on Healthcare's focus on this crisis. The Direct Care Worker Amendment Act of 2023 makes several changes to licensing and competency requirements for the NAPs in the district. This bill replaces the existing HHA and CNA certificate with the new Direct Care Worker Certificate. To facilitate this new certification, DC Health and the Board of Nursing would need to establish a new competency standards for these new professionals. The legislation allows DCWs to serve in a variety of titles, presenting themselves professionally, including a CNA. For existing HHAs and CNAs, the bill provides a pathway to certification as a DCW, which requires demonstration of the relevant competency. The legislation also allows HHAs certified in Maryland or Virginia to practice in the district without needing to become certified in the district. DC Health has significant concerns with several elements of this bill, a sentiment that was shared unanimously by the Board of Nursing at their March 6, 2024 meeting. Primarily, the lack of a requirement for eligible professionals from Maryland and Virginia to certify in the district presents a safety concern for patients. The Board of Nursing is responsible for acting when discipline is warranted. Among all these complaints received by the board, a considerable amount came from unprofessional conduct, such as sexual misconduct and abuse that was allegedly committed by HHAs and CNAs, something that highlights the importance of this oversight role for the board. This bill allows CNAs and HHAs in good standing in Maryland and Virginia to not need to certify within the district, and therefore neither DC Health nor the Board of Nursing would have any oversight or authority and not be aware of those professionals working here in DC. Instead, the district would need to work with our neighboring jurisdictions to ensure that we are made aware of potential concerns. This would delay or potentially avoid disciplinary action, including a summary suspension of license, which would put the public at risk. This is particularly concerning given the vulnerable populations that DCWs would serve. Additionally, this lack of certification requirement for neighboring professionals would result in those professions delivering care in the district without having met the DCW requirements. This includes successful completion of a criminal background check, something that Virginia does not require. Similarly, neighboring professionals would not be subject to the district workforce survey requirements, leaving DC Health ill-informed as to the overall NAP workforce landscape. While this essential part of the healthcare workforce is experiencing shortages, its important and relevant competencies and ultimately patient welfare and safety is not to be compromised. The legislation states that the existing HHAs and CNAs shall automatically qualify for certification as a direct care worker, able to work in any healthcare setting, demonstrating that they possess the competencies to practice as a direct care worker. Under existing curricula, CNAs are not trained to provide care in the home, and HHAs do not receive training about long-term care or acute healthcare facilities. Without a carefully designed process to ensure competency among existing NAPs, it would be inappropriate and unsafe to merge CNAs and HNAs into a single profession. For professionals seeking to join the DCW workforce going forward, DC Health would need to develop a new curriculum to ensure they have met these required competencies. This requirement presents a significant challenge for the board given the one-year time constraint. Additionally, it will likely put measure on educational providers within the district who have to make significant changes to their existing programs. DC Health also has concerns with the nomenclature being proposed with this new category of healthcare professional. Should this bill pass, the district would be the only jurisdiction in the United States in which the Healthcare Professional Licensing Board certifies a profession with this license name and scope. This would make the certification by endorsement process even more challenging for other jurisdictions, as they may not be familiar with this type of certification. Additionally, the ability for DCWs to use a variety of titles may cause confusion for healthcare providers and patients, both within and outside the district. This may lead to stakeholders not being clear as to what license a NAP professional might hold. Similarly, there are federal requirements that states mandatory registry of CNAs within their jurisdiction, something that currently is undertaken by DC Health. DC Health would need to make clarification through rulemaking to ensure the district remains compliant with the federal requirements. While DC Health appreciates the committee's efforts to address the underlying NAP workforce shortages, we have concerns that will not achieve the desired goal. While this legislation will allow professionals already licensed in the district to transition between settings more easily, it does not directly contribute to an increase in the overall workforce. In fact, there are concerns that may exclude existing professionals who are unable to meet the new educational requirements by this bill. Currently, there are hundreds of NAPs who do not have and are not pursuing a high school degree or equivalent diploma. These professionals would therefore be unable to attain a certification as a DCW and would be forced to leave the workforce. This has serious equity implications, as 77% of the HHAs in the district are Black women and many come from immigrant backgrounds. DC Health understands the value of acquiring such an educational standard. However, without additional support, it is unlikely that those without a high school diploma or equivalent diploma would stay in the profession. This would undercut the very intent of the bill by reducing the number of certified NAPs. DC Health is committed to making it easier for NAPs to practice in a variety of settings, as well as growing a pool of professionals practicing in the district. The Board of Nursing actively collaborates with education providers to reduce barriers to the training programs. These ongoing efforts will provide aspiring healthcare professionals with the opportunity to receive the necessary education to practice as a NAP. DC Health is also working to implement the High Need Healthcare Career Scholarship. This program will provide scholarship and supports for eligible students to become NAPs in the district. This program will reduce a significant burden to professionals entering the workforce and therefore should address this NAP underlying shortage. DC Health also included allowing individuals age 16 and older to work as NAPs as they pursue their certification. Finally, DC Health is working on emergency regulations that allow CNAs to practice in a home-based environment should they attain an attestation from an RN. Additionally, these regulations would streamline the endorsement process from individuals coming from Maryland and Virginia. While these emergency regulations do not bring new professionals into the workforce, something this bill does not do either, it will promote professionals being able to work across the region while protecting DC Health's regulatory role. In conclusion, DC Health appreciates the intent of the legislation to address the district's NAPS workforce, but recommends a larger conversation about workforce challenges while the agency works through rulemaking and existing programs to expand educational opportunities, to allow CNAs to work at home-based settings and streamline the endorsement pathway. These will not only promote the growth within the workforce and the portability across the region, but also continue to ensure patient safety in the district is prioritized. We look forward to your continued collaboration with you and the committee on a whole, and thank you for this opportunity to testify, and I'm available for any questions. Thank you.
Thank you. Director Turnage?
Thank you.
Oh, sorry.
Thank you, Chairperson Henderson, for the opportunity to offer DHCF's perspective on the Direct Care Worker Amendment Act of 2023. I'm joined at the table by Melissa Bird, our very capable Medicaid director, and Angelique Martin, our Senior Deputy of Finance at DHCF. She is the master cook of our reimbursement methodologies, and she's aided by a team of very, very talented analysts. In discussing this bill, I'll move very quickly, but I want to hopefully discuss it in the context of what we currently do and how we believe this bill differs and is not very helpful. And I want to address some really specious claims that have been made against DHCF's reimbursement system. We believe that our tiered payment system is infinitely superior to that which is contemplated by the proposed bill because of the administrative flexibility it provides employers without sacrificing wage levels. And you can always adjust the wage levels in a tiered system as long as you got the money. So if you give them the flexibility, it's just a matter of the mayor and the council coming to some agreement on how much money they want to put in the system. We have the system set up to work precisely in that manner. I'm going to skip through the history of how we got there because I know you're pressed for time. I'll jump you to slide 7. That was the calendar year that we phased in this tiered system for virtually all of the HCBS providers with an initial supplemental payment that is, and if those providers could demonstrate that they paid an average of 110% of the living wage, they would get that supplemental payment. The final payment is scheduled for the summer of 2024, and it will have increased DSPS wages to an average of 117.6% of the living wage. The reason we distinguish this from the language in the direct in the bill that we're discussing is because when you set up an average, there's a obvious minimum, average, and a maximum. We can then develop costs based on the distribution of our workers around those 3 data points. The language in the Direct Worker Reimbursement Act has no provision for such. Now, if you look at our payment model, why is it so much better in my judgment? It has this great flexibility. First of all, we use the legally mandated living wage as the minimum payment floor. We don't establish a maximum threshold. You can pay as much as you want to pay, as long as there's a 117.6% average reflected across your workforce. And by 2025, all of the enhanced wages that we started working on in 23, calendar year 23 for all of the HCBS professionals will have been well incorporated into the provider operations, those who deploy this approach. If you go to slide 8, it gives you some indication of how this has fueled growth in the wage rate. As you see, the wage rate from 23 to 24, in 23, there was an increase of 10%. By 24 was an increase of 17.6%. So you have now high tier workers making over almost $24 per hour. We think this system reflects the objectives that we've heard from home care providers as to what they want to pursue when they try to execute a wage system. If you go to slide 9, because of that growth you saw in the wage rate, you also see the growth in total payments to direct care workers, growing from 58.7 million in calendar year 23 to over 73 million in calendar year 24. So I'll quickly summarize on slide 10 the 3 major benefits that accrue to the system that Angelique designed with her capable team. The tier agencies can pay higher wages to more experienced employees, responsibly containing overall wage costs while creating incentives for new workers who commit to the agency. Tiers can be used as a form of merit-based pay, thereby compensating more productive employees, again, without significantly increasing or irresponsibly increasing overall wage costs. And tiers mitigate problems of wage compression between managers and new employees, which can be absolutely ruinous to the morale of employees whose resume and tenure present a legitimate argument for meaningful differences in pay. I want to turn quickly to slide 11. And what we did, we've modeled the fiscal impact using assumptions about fiscal year 25 of what the 3 systems would cost. First system on your right is the one that we currently operate. A tier system with a 117% 0.6 base average. In fiscal year 25, we estimate the cost will be 73.6 million, 22 million of that will be local. If you go to the flat rate system as your bill contemplates, and that some of the people who were behind it tried to walk it back, saying they didn't mean it to be flat rate, but that's what we would have to treat it given the way that it's written. That's if you fund flat rate at 120%, it doesn't do that much difference in terms of cost than a tiered system. Tier system, the flat rate does bring in about $2 million more, but you lose all that flexibility that we just discussed. Now, so what happens if you take the 120 base rate in the bill and then drop a tiered system on top of it? So we estimated what their cost would be, and it's 117 million total. The local cost would increase by almost $11 million, and you would have your tiered system with the base rate of 120%. Now, the hard work has been done. The only question is, if you all want to fund it at their level, can you find the dollars? As you know, we are in a terrible budget that the mayor will present to you and your colleagues next Wednesday. So we think the framework is there to do as much as the district wants to do with respect to rates for direct care workers. And so I looked at the criticisms in the letter of introduction, and frankly, I think they're just without merit. There was one said our system is convoluted. The system is premised on a simple average. Right? It's just basic math. It's not convoluted at all. You know, you look at the distribution, you calculate an average, look at the distribution of workers, and use the minimum and the maximum to figure out how much it's going to cost you going forward. The system is difficult to administer. I don't understand that one at all. People say, well, you got people coming in and out. How can you keep track of averages? A simple spreadsheet. it'll calculate your average on as many times as you want in milliseconds. And the system is not transparent to employees. This is where I think folks don't understand how we do reimbursement at DHCF. We do not burden employees with the responsibility of assessing their employer's compliance with reimbursement rules. That's our job. That responsibility immutably rests with us, and we cannot export that to the providers or the employees. Now, the last key point I want to make before one slightly editorial comment is setting labor market rates, and I want people to listen to this very carefully. That is not the job of DHCF. We don't set the labor market rates. That's not our responsibility. I know people are urging us to take on a greater role, but a mandated and artificial increase in wage levels calls for assumptions about what we call equilibrium price, that frankly, that price of the true cost of labor that we're not qualified to make. We have an employment agency that makes those decisions. So that's the first point. And for some reason, the letter of introduction assumes without evidence that I could determine that 120% of the living wage is an equilibrium price for labor for direct care workers. I don't know that it is. It might be, but it might not be. We're just not qualified to make that assumption. We do not prescribe wage levels for any Medicaid provider groups, and we always approach with great caution and any request that we do so. What we do as an alternative is allow the providers to respond to the needs of the market and their organization with voluntary adjustments in their wage scale. Now, so to make that point, I ask you this. When was the last time a hospital, a SNF, an ICF have come to you and said, DHCF is not paying our workers enough? They don't come say that. You know why? Because they set their own wage rates. What we do is we get audited cost reports from them, and we look at their reasonable costs, and we adjust their reimbursements, in some cases annually, in some cases in 5-year increments, with inflation adjustments in between. But we never go in and tell a hospital, a SNF, okay, you can only pay this person this amount. You pay them what you need to pay them to get them to come work for you. Now, do we do that for home care agencies? No, but you know what? It's not our problem. It's not our fault, I should say. You know why? We have asked home care agencies since what year, Angelique?
2019.
2019 to submit audited cost reports. We've asked DD waiver providers to submit audited cost reports. The respective compliance rate is about 29 and 56%. So because we don't have audited cost reports, we can't use the same system that's very flexible, that makes sure that they have a very little time lapse between when they raise wages and when we pay for the higher wage, because we don't have the audited cost reports. We cannot overpay, so we need those audited cost reports. They have not been able to give them to us. So I think this system is perfectly positioned to address any wage concern that employers have, because we have a tiered system in place, and you all can adjust the wage triggers at whatever level you want. But I do caution, it is a perilous duty for a government to try to figure out what is an equilibrium price for labor in the market. The market is very, very tricky, and the agencies have to determine that, and then they set their own wage rates. So I will close, Madam Chair, by saying I think it's important to address some of the unfortunate comments that have come across my desk and made about DHCF staff as a part of what I acknowledge is fierce advocacy around this issue. And this advocacy is, we don't shrink from fierce advocacy. We know these are heated issues. These are very important issues. We serve very vulnerable employees. I know what it's like. I'm a caregiver, and I know what it's like for people to count on you to be there. So in email communications and in rather thinly veiled comments by some, DHCF's leadership has been characterized essentially as a cabal of insensitive bureaucrats who are turning a blind eye to a problem that at least one primary advocate has described as a vestige of institutional racism. I think the term she used was apartheid. That's what she said in an email communication. I work with some of the finest people that I've ever known. And I think I have been Black all of my life. Not like the person who leveled this comment at us. The last thing we would ever do is preside over a system that intentionally injures people who are mostly Black and brown, and who are caring for mostly Black and brown people. That is just highly offensive, and it could not go unchallenged. And not surprisingly, not once in these communications on this issue do they deign to mention that the district has a system in place that will fund DSP workers at the highest levels in the region relative to our Medicaid peers. And as was discussed by PHI, we rank very high on policy issues. Now, that wage competitiveness, I want to talk to them about that because I think those numbers are before we made these adjustments in our system. So when you have that kind of intellectual dishonesty and it occurs infrequently, you can dismiss it as, musings of the uninformed. But when it occurs repeatedly, it smacks of a cynical ploy to pollute the debate on this issue with a false narrative or perhaps a version of alternative facts, which unfortunately do not confirm with objective reality, nor does it advance meaningful discussions around possible reforms. We are very much interested in doing whatever the providers need to make sure they have a workforce that can treat and care for our most vulnerable residents in this city. We've set up the framework of a system to do it, and now we are a prisoner to the budget, the forecast, other costs in government, but you know that better than I do. Thank you.
Thank you, both, for your testimony. I just have a few questions, and we can move on. Director Turner, I'll start with you since you were the last to speak. I hear you when you say you believe that it is a peerless duty for the government to set the market, but is it not true that given the number of Medicaid recipients who are receiving PCA services, you do set the market in terms of what the reimbursement rate is?
No, their demand for labor sets the market. Their demand for the provider's demand for their labor sets the market. We can't predict that. So what we need to do is to give providers the flexibility to pay what they need to pay to get workers in. I think this system does that.
Right, but let's go back though. Okay, so let's say I am a provider. Your reimbursement rate gives us, I don't know, let's say $20 an hour. I'm paying 17, which is not, I'm paying 17.
Correct.
I'm having a difficult time getting in workers, but you're not going above 20. And my administrative costs, I need that 3. We
will go above 20. There are people in this system that are making $23 an hour.
Work with me on a hypothetical system.
Okay, I'll work with you on a hypothetical.
Okay. What I'm saying is, if the majority of the cash flow that I'm getting in are from Medicaid patients, do you not set the market in terms of how much I can pay? Because what I have is basically based on the reimbursement model.
Yes, the providers whose business is 80 and 90% Medicaid are certainly tied to the reimbursement that they can get from the program. But what I'm saying is, all the providers have to do is to give us an audited cost report that where they identify their reasonable costs, and we can look at those costs and we can tweak their rates in between the years. We don't have to wait, 5 or 6 years. We can look at your cost reports. We can say, geez, their costs last year were a lot higher than we anticipated. Let's tweak their rates. We have the SPAs in place that allow us to do it. But if you don't give us an audited cost report, we can't guess about what your labor costs are.
So why are the audited cost reports voluntary?
Well, because if we make them mandatory and they don't comply, and you think there's a shortage of workers now, it would be a disaster. Because you would probably lose. What's the compliance rate for home health agencies?
Oh, use your mic, Angelique. Thanks.
Right now.
Oh, we gotta pull, thank you.
The last audit reports that we collected, out of 25 providers, only 14 submitted for home health agencies, so that's 56%. And then for DD waiver providers, 28 submitted of 96 providers. It's more recent, it's FY 22. So DD waiver providers are normally compliant. They have a little bit more time to submit, but I think it's important to understand the base of our current rate system is based on living wage that's set by DOES, and that is based on CPI as well as BLS data. So the Bureau of Labor Statistics and the DC cost of living is what determines that 1750. So any question against the 1750 would suggest that as a district, we don't have a sufficient living wage for people who work in the district.
I would say that's correct, yes.
Medicaid's responsibility is to support that living wage requirement. So it's not we cannot set, if they choose to pay $25, if there's not the legislation in place to support that $25, Medicaid has to pay based on what the requirements are.
Okay, so federal Medicaid requirements pays based on whatever the living wage piece is. So
Correct.
that's
And if
driving.
we shift to cost base, like our institutional settings, then we are able to take into consideration reasonable cost. So when you look at institutional settings, we, as Director Turnage previously mentioned, we don't tell them how much to pay, but they determine how much they pay looking at living wage and what competitive rates are.
Yeah.
And then that is considered.
Okay.
So our goal is to get a system in place across all provider groups that helps us respond efficiently to the market changes that are the labor change, the wage rates that are driven by market changes in the workforce. That's what we try to do. We can do it with hospitals. We can do it with all the other institutional providers. It is very difficult to do it for home care agencies and the DD waiver programs because of the absence of audited cost reports that allow us to make cost-based reimbursements.
So what's the hesitancy that the providers say to turn in these audited cost reports?
Angelique can speak to it better than I could.
So when it was originally established, DCHCF intended for cost reports to be mandatory for both of the providers. The hesitance was, this was right after, so this is 2019. So it was a few years after the fraud issue in home health agencies.
Yep.
The concern was the impacts that submitted audited cost reports would have. Because when you submit a cost report, you submit your costs that you spent. When it's audited, if there are costs that are unreasonable or you're not able to submit information to support it, data to support it, then that cost is disallowed.
Oh, so it's like fear of telling on oneself.
Yeah, well, I'll
Basically,
give you a case example. We had when we first started in 19, one home health provider submitted a cost report with the cost of their children's education, farm equipment.
Wait, I'm sorry, their children's education?
Yeah, well, they were relatively inexperienced in the ask. And so we understood that, you know, sometimes when you're dealing with certain mom and pop operations, they don't have the administrative wherewithal to hire, you know, high-priced accountants that can develop and fill out cost reports. So we said we give them some time. But we had to make it very clear that just because you put it on the cost report, it doesn't mean it's a reasonable or allowable cost.
Exactly. So they have grown, and some of them have gotten better at understanding their costs. We've also provided technical assistance to help them understand how to have proper business models to support their cost. And now we have 2 rate studies going on. One is with the DD waiver program under DDS, and then the other one is for home health agencies. And during both of these processes, we are reviewing their cost. And we are also taking into consideration what is occurring in the workforce to determine what shifts and changes we can make in the current methodologies to help support some of the concerns that have been brought up today. Going to a cost-based rate methodology is helpful. Shifting the methodology from a unit base to a bundled rate also gives that flexibility, allows them to direct their costs where needed. And so hopefully through the end of the home health audit and the DD waiver audit, we'll be able to, rate study, we'll be able to get to the point where we can shift to a cost-based methodology that allows us to make consideration based on submitted cost.
Okay, so if folks have not been responding in terms of the audit reports, how confident are you that you're going to receive the information necessary for the rate study for home health aides or other support professionals?
Because in our communication that we've had with both provider sets, we have continuously asked them for the cost information, and we have let them know, if you don't give us the information, you can't be upset with us when your added cost or additional costs are not considered when we're determining what rates should be. Because we have the BLS data. We have the regional rates that our DSPs and other professionals are being paid. So we have that information. If you don't give us the information from your point of view, then we have to make decisions based on the data that's been submitted. And if it's not, it doesn't give a full picture of the providers across, only the ones that submitted.
Yeah.
You can't be mad because it's an industry-wide rate. It's
Right.
not
So if you only have
provider specific.
56% participation as you have in the one, you guys are still going to make a determination based on the 56%.
Right.
Absolutely. And consider home health agencies and DD waiver providers. They're different sizes. They provide care to different acuity level patients with acuity levels. They're different. And so while we have an industry-wide base, it's important to have considerations of each type of provider
Now,
to make decisions.
I would ask you how many times the director of the association has come to you with these incontrovertible facts? Probably zero. We can also go nuclear, but you'd have to back us up. And that would be, we can say, if you don't submit an audited cost report, then you're not going to be eligible for reimbursement. Now, that's nuclear. And it will cause a lot of angst. And they'll come straight to you and say, look what DHCF is doing now.
Yeah, but at the same time, you come here and you say, I can't find workers because we're not paying enough.
That's
So
right. That's right.
we got to pick a struggle. Like either you want us to pick the number or you provide the information,
That's
therefore we
exactly
can,
And I think they would it would be to their considerable benefit to do audited cost reports, to get faster increases in their wage rates, and to get wage rates that may be appreciably higher.
okay. So for individuals who currently submit their audited cost reports now, I'd imagine that these are your larger agencies, et cetera. Are you making adjustments?
Oh, yeah.
So they are not necessarily our largest providers.
Oh,
One
okay.
of our largest providers that provide services across many provider types are one of the main agencies that do not submit a cost report. So I can follow up with the buckets of providers, if you will.
Okay.
And how many of the providers that have submitted fall into these various.
Are you guys not skeptical of these companies who don't submit their audit cost
We're
reports?
very skeptical, but again, we have to make sure that we don't upset the market in ways that create supply crisis.
Understood, but
Yeah.
on the back end, right? I got the inspector general down the street who every other week is releasing a press release about
Absolutely.
people who have
Now, we've done a lot,
stolen.
and Melissa can tell you about some of the changes we made on the care worker side that help us identify fraud. Before we get to that, I thought you were asking about the adjustments we make to providers who do cost-based that are not home care agencies. Hospitals, we do an annual adjustment to their rates. SNFs, we do 5 years, but we do interim adjustments when we see problems, like they're going to get in the midst of a tough budget, they're going to get an increase.
But in terms of like, let's say when you do it for the hospitals, you get,
The hospital data is pristine.
well, yeah, I mean,
I just want to let you know.
let's say I'm Sibley and she's GW. If I submit mine first, will you process me before she submits hers? Or do you have to wait for both of us to submit in order for our situations to be processed?
We have a reimbursement schedule at Angelique. Angelique manages that whole process. Everybody gets adjusted at the same time. But you can.
Yes, everybody gets adjusted at the same time, but your question is a moot point because they submit. They may ask for an extension. They may ask for an extension. We may have to give them 30 or 60 days, but they provide the information timely and complete.
And if they don't,
when we don't,
Jackie, we go to the head of DHCA.
Yeah.
And she rides herd on them. We don't have that option with HHA. They don't have that. We don't have that resource.
Okay. So
They choose.
overall, let's back out, right? one of the things that we've heard from today in terms of some of the challenges that we're having in this particular profession on the workforce side is around pay. Do you believe that that is not the case?
That's a very good question. I don't know if it's clearly there's a number that if you said we're gonna pay direct care workers $35 an hour, you won't have any problem finding direct care workers. But is that something that you should do? Does that reflect a responsible reimbursement strategy? I would say no. But I will also say I have no idea what the equilibrium price is for direct care worker labor. I just don't know.
So who figures that out?
Well, we have a Department of, DOE, but DOE sets district living wages, and they leave it to employers to pay beyond it if they need. So it is essentially, and I hate to say this, but it's true. It's the employer's job to figure out how much they have to pay to get somebody to come work for them.
Yes, but again, I go back to, if I'm a company where 80% of my folks are Medicaid recipients, then you are technically my person.
UMC, almost 90% of UMC's business is Medicaid. We have no problem getting cost reports. We have no problems adjusting their rates.
You comparing a hospital to a home health agency though.
Well,
we have SNFs that are the same. I'm sorry.
Go ahead.
We
No,
have
go
skilled nursing facilities that are the same, where they are majority Medicaid, and they may submit it 30 days late, but they submit their cost report. I think in response to your question, I think what helps them is when any worker in the district or anywhere, whatever setting they're working in, they want stability. They want to be able to know while they're in that position, that while they're working on education, certification, that there is some type of upward mobility in their future where they are. So if you have somebody that loves being a DSP and they want to work there versus be getting a higher certification in another job, they need some type of career ladder within their current job. And
well, I think
that's more encouraging than just dollars.
We had a witness who testified today. She started as a server, then she went for a CNA, then she got her LPN, she got her RN, and then she became the director of nursing all in the same facility. So the ladder is there.
Yeah.
Now, obviously she's working in a facility, not in someone's home. So that's a different type of situation. But I don't want to suggest that there is no ladder in this profession.
No, I'm not suggesting that. What I am suggesting is that a person that is in an entry-level position, while they're working on getting those certifications, while they're working on that process, if they choose to move forward, they would like career stability within their current role. So with the tiered model, if you're coming in the door and you're making minimum wage, that there's a trajectory as you're working on what your future will hold, regardless of whether you choose to stay there because you love your job or you choose to move forward and get the higher accredited positions in the healthcare field.
Okay. So I was going to ask a question, but if you guys aren't getting the audited cost reports, then I think I already know the answer, but I'm asking anyway. So we currently have the average of 117%, 117.6%. I was going to ask, have we looked to see what the range is? Are the vast majority of workers at the low end and you have a couple of high paying execs, and then how would we do that analysis? Have we ever done that analysis?
One of our requirements for the enhanced wage is that they are to submit a report, including individual, so their DSPs.
Yep.
And you asked this in our last hearing too, but it includes all of the DSPs and what they're paying at each stage. So in January, and then by July, and then again in the following January. And so we can see by DSP the average of how much they're paying across their DSPs. And I can provide that to you, but I know right now 67% of our providers are utilizing the tier model.
Okay. So let's say we could keep tier. You okay with raising the base?
I'm not, that's above my pay grade.
Lord.
We can certainly propose based on what we see in the data, but, we're prisoner to what happens in, with the district's forecast and what happens with the cost of all of government. It is a very, very difficult budget. And,
Okay.
those decisions have to be made that may prevent us from getting all that we want. And it's fair.
Okay, but so I'll turn to Dr. Walsh because, in her testimony, she said we're gonna have a 44% increase in demand for nurse assistant personnel. You refer to them as NAPs. Y'all have weird acronyms for all of these things. NAPs, SNFs, all the pieces by 2036. How do we get there? Dr. Walsh?
I'm sorry, how do we get there?
Yeah.
That was a HRSA quotation. So how do we get there? I believe we have to do it through the schools. I think we have to grow them. We have to give them a tiered model to let them get up and climb the professional ladder. Just as the person who testified, I worked in high school as a nursing assistant. I would walk from high school and go to the nursing home, and I did the same thing. So I think we have to embrace that in our educational facilities. I know that we have Coolidge now, trained CNAs, and I think we need to continue to expand that so that we can reward students and make it a positive professional thing in the future.
Okay. I have to say, I'm a little surprised from your testimony in the opposition to a unified license, especially because at the December hearing for the HORA, I asked DC health staff how they felt about this, and they testified that the Board of Nursing had no problems. And so now this is a problem for you all. What changed?
So we presented the bill to the board at the last board meeting, and they discussed it. And I think the thing that is concerning about it is twofold. The first is that there's no regulatory role for individuals that come from Maryland and Virginia into the district. They would automatically be certified.
Well, let's separate the issues. I'm asking specifically about combining the HHA and the CNA.
Okay, sure. So to be quite honest, if that is something that you want to go, it would be changing the title of the DCW probably to a CNA. But the HHA does primarily focus on the home setting, as the gentleman, I felt so bad for him too, as he pointed out in his testimony. And the CNA is basically in long-term care, things of that nature, assisted living. So the competencies are different.
Okay.
For an HHA, you have to know how to evacuate someone in a fire, right? You have to know, okay, we've got 10 flights of stairs here. How am I going to get them out if it's a fire? You have different standards that are targeted for those facilities for CNAs and HHAs.
Understood. Okay, so we had a witness who testified that Maryland is considering legislation right now to unify their credential. Have you all looked at that?
We've had several conversations with the ED of Maryland, Rhonda Scott. I actually reached out to Aisha, the team did, and we've had no updates about that. But Rhonda did do a crosswalk with us for Maryland. The thing that's different in Maryland about their CNAs, which is equivalent to our HHA, is they don't take an exam. They do not take an exam. So our HHAs and CNAs take a national exam.
Okay.
And the CNAs in Maryland do not take an exam. The CNAs in Maryland primarily work in the home. The GNAs in Maryland take the exam and are kind of like the blanket.
Yeah, everybody has a different. Can we just all get on the same
Yes,
page?
it's the challenging thing, and it is.
Now, what does GNA stand for?
Geriatric nursing assistant.
Which
So
is-
again,
so
long-term care.
is that the equivalent of our CNA?
Yes, ma'am.
Okay.
And that is a challenge that's been actually brought to the national level. So, the level playing field is registered nurse, everybody at National Council, they all get that, okay. But, everybody's kind of across the board with this NAP. I know, the acronyms, but everybody's kind of across the board, state to state with the NAP.
Okay.
And it does make it difficult, but I think this was brought up in the testimony. If we can get the three states, Maryland, DC, and Virginia.
That's all. I mean, other states are cute, but I really care about the region in terms of getting us on the same page. Obviously, I know from previous conversations about reciprocity agreements, we have the issue that the Commonwealth of Virginia does not require a background check.
Yes, ma'am.
Which is strange. I'm not a legislator there, so you know, they let it go. But as we have these conversations about reciprocity agreements, I feel like our tri-state area here should get really tight and be connected with each other on this.
And we definitely are in conversations. Rhonda's been in the role at Maryland for a very short time, so she's trying to get her running shoes on and get going, but she's very open and willing to work with us. And we get most of our HHAs and CNAs from Maryland. It's the vast majority, not that many from Virginia, but mostly in Maryland.
Okay, so what you're saying is if we did combine the license, we need to change the name to something more nationally recognized.
Correct. That's my belief, and actually for the board. And again, we want to be able to regulate, you know, that poor man, again, I go back to his testimony because it was so
Everyone
touching.
at the beginning of this hearing, I like my heart broke for them. But then I'm also, you know, in that, right, we have a worker shortage. You're saying we need increased demand. I'm looking at the numbers in terms of certification. And then you're also saying, though, you guys don't like bringing in someone from Maryland or Virginia. But I got residents who are saying, if there is no one, I am literally sitting in my room just waiting.
Right. But he also said competent. And that's what I, for the Board of Nursing, want to make sure that that person comes in there and is professional, doesn't steal his money, knows how to change him. And for us to have some teeth in the game, we have to have the regulations. That's what the Board of Nursing does. Because if I get a complaint on that, I want to be able to go back and say, look, this person is not competent. They don't need to be licensed. They're actually going to hurt somebody. And I think that's the biggest thing for the board is they want to make sure that people are being taken care of safely.
Okay, so from 2020 to 2023, we allowed CNAs and HHAs from Virginia and Maryland to operate here. How many complaints did we get?
I have to get back to you on that. I don't know. I know that it was in the pandemic also, so I'd have to get back to you on that.
Okay.
I don't have that number.
I mean, I think that's important. If you're
Yes.
making an argument around this is going to be very detrimental to the safety of residents, we have a 3-year pilot window here. It's good to evaluate what happened during that 3 years. And I'm not to say that I'm sure there were incidents because things were crazy. I'm sure there was. But at the same time, if I've got how many, I wrote it down. How many decrease? Hold on. I said it at the beginning of my testimony.
Are you looking for my testimony?
No, I said it. Oh, yeah.
Okay, got it.
We have 4,500 less CNAs and HHS renewed their certification in October of 2023. 4,500, 30% of the entire workforce. So I understand, I want us to grow our people, but I also know I can't grow them at the rate that I also need them today. So I'm trying to figure out how to do it from both ways. And this is one where providers are telling me it worked. At least for the last 3 years, it worked.
Yeah, so I will get back to you with the number of complaints, but I also want to bring something to the table is we don't want to rob Peter to pay Paul. You know, the workforce, I've been a nurse over 40 years. This has been an issue for a long time. So we have to think out of the box in terms of education, culturally, sociologically. How do we get young people to be involved in this and move forward? It's definitely worse now because we're aging and because of healthcare, we're all living longer, right?
Yeah.
But I don't think we need to rob Peter to pay Paul in that when I heard the first lady, Miss Nolan, she said her one CNA has 22 patients, right? And then other people say that they have one-on-one. So I want to make sure if we open up this door, everyone doesn't exit the nursing homes and come to work as an HHA.
Yeah.
I think that is a legitimate concern for us.
I mean, we also heard from several workers, and there was one, Tarnisha Rogers, right? She has both the CNA and the HHA, and she was like, I just want double the opportunity. I think she also works multiple jobs. So like you leave your home health aide position and you're going to work in a facility.
Yes.
But also all of the actual workers who testified today talked about working multiple shifts, doubles, triples, just trying to make ends meet, but also wanting to make sure that their clients are taken care of because, you know, there's no overtime anymore, right?
Oh, providers can pay overtime. They will tell you this, it's not in their wage, but it's their job to cover the case. See, if they had audited cost reports, that overtime would be reflected and it would immediately adjust their rates. But
PSA, turning your audited cost report.
But very quickly, just to show you the dilemma, if we had been presented with a correct version of the bill that you have doing budget development, and it was written so that it was a tier system with a 120% base, we would have had to decide at DCHCF whether or not we would submit that as an enhancement. So Darren would have done a fiscal impact statement and told us, this is going to cost you $11 million more annually. And then you spread that over the financial plan, that's $44 million. In this budget environment, I would not have submitted that enhancement. I just wouldn't, because I thought it would be irresponsible.
Understood.
Yeah.
I don't think any. I don't think anyone
Right.
It was not my expectation that this would have been in the mayor's budget next week. I knew it was going to be expensive.
Okay.
But I think that overall, and I think we heard this from a lot of the public witnesses who testified today, they don't feel like the district has a plan to address the shortage issues that we're seeing coming down the pike in a very, very quick fashion, right? A number of lovely witnesses who testified today in person, in their 70s and 80s, all mobile, none of them needing these services, but they're concerned that when the day comes where them or their loved one needs one, it's not going to be there.
Right.
So they're advocating now. And to them, it's like, okay, so what's our plan? What's our plan to grow the workforce and do all of these pieces? I mean,
fair.
I hear Dr. Walsh, I hear you talking about the schools piece, but I have a similar concern. I feel like we're being very passive with it in some ways. I'll give you an example. So I've had lots of conversations with Chief Donnelly at FEMS around their need for more EMTs and seeing that as a pathway of us, again, to be able to grow folks in the healthcare workforce pipeline. We have a lot of people who start as EMTs and sometimes they'll become nurses and then, move on. They're on their fourth. We have an EMT training program at Eastern. It hasn't graduated a single person.
Ooh.
Right? So you say yes, so Coolidge is doing the CNAs. Are they going to graduate somebody? I don't know. But also, are we talking about it as like, these are our health professional pipeline programs, and we as the district are going to invest in, these various pieces. Let me ask in sort of this workforce conversation, Director Turner, I'm asking you in your deputy mayor hat, but you could talk about it from the healthcare finance perspective too, and the same for Dr. Walsh. Has either agency met with OSSI or the Workforce Investment Council to discuss the workforce needs of the long-term care sector?
Deputy Mayor's office has not. No, I can't speak for DC Health.
So to answer that, I meet with OSSI, not directly on this, but I meet with them probably every other week about workforce in terms of how many schools are applying, how many people are in the programs, how we approve the programs from an educational and pedagogical, as well as connected to the nursing. Directly in terms of workforce, we do the workforce survey. Hopefully that will be out by the end of the month. And it has some great data from the HHAs, I must say. So I do meet with them regularly, but specifically on the workforce, not that detailed. I had a follow-up on the registration, the numbers, when you said how many complaints. So part of the challenge with that is during the COVID, we just let people come in and they didn't register with the district. NAPS. So that is a problem because we don't know who's working here, right? So they just come in, they show their Maryland thing, they don't register. So we can get back with you with more data with that, but we really don't know the denominator when it comes to that.
Okay.
Right.
But you would know how many people, I mean, if I'm a district resident and I had an issue.
Correct. Yes,
I would have.
Yeah. But then
downloaded your complaint form to email it back to you.
Right. But then where's my teeth to get that person that's not registered with us? I'd have to go to Maryland and.
Okay. Would you all be open to this if we required that they had to register?
Can I consult Mr. Gibson? Sure. Okay. So we're going to take that back to the leadership. Thank you.
Okay. The bill proposes to lower the age for direct care workers, or we'll put that in quotation marks as we think of another name, to 16. There's a similar proposal in the HORA. However, in the HORA, you all made this a temporary certification, and that individuals will have to reapply for their certification when they were 18. Am I correct that this is only to ensure that they submit the criminal background check because you can't do a background check when you're 16?
Let me consult the attorney. I believe so, but I don't want to speak. That's correct, yeah.
Okay.
Thank you.
Then why not give them a permanent certification and just require them to submit a criminal background check within 3 months of turning 18? I guess my question and or concern is that let's say I'm 17, I've paid now to go through the certification process, and then when I'm 18, I have to pay again, even though nothing has changed except for my age, and I have to get a background check. Does that make sense?
Yeah, I understand what you're saying. I need to take that back because I'm not sure that, I thought that they would only pay for the CBC, but I'm not 100% sure, so I got to take that back.
Okay.
Yeah, I'm not 100% sure. You know?
On that particular piece, let's clarify that before next Thursday, because that one's in the bill that we're marking up next week.
Yes, ma'am.
Okay, great.
Yes, ma'am.
Okay, this bill proposes only allowing direct care workers under 18 to work in a facility. But in the horror proposal, DC Health does not propose a similar restriction. Does DC Health believe there are no increased risks associated with letting someone who's under the age of 18 work in a home setting?
That was not my understanding. And Robbie? So the details would be in the rulemaking, and that has not occurred yet.
Okay.
Yeah.
So you all would want to leave it broad and then you make it in the rulemaking.
Yeah.
Okay. All right, we're almost there. If we were to combine the HHA and CNA certification, what type of ramp up period would you guys need?
Again, I'm going to take that back to leadership, but the discussions did talk about, it was about a year, correct? Did we? Yeah, I have to take that back, but I do know that there were discussions about a year. All right, Arian's gonna come here.
Come on, Arian. If you would just introduce yourself for the record.
Arian Gibson, Senior Deputy Director for Health Regulation and License Administration within DC Health.
Great. How long would it take?
So just for that change, not everything else, we're just talking about combining it.
Yeah.
So we can combine it relatively quickly if we leave in the name as a CNA. The major part for that would be to make sure that the HHAs has some sort of bridge to bridge the gap between the CNAs. For us, administratively, we already have a system in place in which they apply for, so that's not a big deal.
Okay. All righty.
Yeah, that crosswalk's done already.
Okay. You said the crosswalk is done?
Yeah, I did it the other night. In my spare time.
Can you share it with us? In your spare time?
We can make sure you get it.
Yes.
Okay. What's the status of the medication aid training program? This credential offers current aides a step up on the career ladder and would pay more money. Employers have expressed a real need to have medication aides.
Yeah, so it's still under review internally. We have not had a nursing educator for a while, and we've been having some staffing changes. So with that, it is internally under review though.
So you need to hire a nursing educator or have a nursing educator on the board?
No, we need to hire a nursing educator. And again, we've had some challenges along with we moved. I don't know if you know, we moved to Southeast.
Oh, no, I know.
Yeah.
But this, the regulations for this training program was established in 2019.
Yes, ma'am.
So I'm just, how much longer?
It's under review. I will again revisit it with Mr. Gibson and the team.
Okay. The bill we're under consideration would require DC Health to review and eliminate barriers to the development and support of on-the-job training programs and registered apprenticeship programs for CNA workforce. To what extent has DC Health started to looking into this issue already?
So you talked about the on-the-job training programs?
Yep, and registered apprenticeship programs in this realm.
So I'm not aware of that. Again, with the gap in the educator, I'm not aware of those conversations with the on-the-job training programs. Are you, Mr. Gibson?
No.
No.
Okay. Give me just 1 second. Okay. One thing I'll just mention. I think we'll know next week, but it would be very disappointing if the health educator position got striked in the budget because it's currently vacant. So we'll revisit that next week and thereafter. I do have a follow-up question for healthcare finance. So there was a witness who mentioned that Edenbridge Pace is able to provide a $21 an hour starting salary because it is based on an actuarial analysis across providers. What is different for them than other facilities?
The program for all-inclusive care, the provider is Edenbridge, but they are capitated much like we capitate a managed care rate. So they are responsible for the total cost of care for an individual. So they receive a per member per month. It does have an actuarial check on it. And then they are at risk for all the costs for that individual, whether it goes higher or lower than the payment that we're making to them.
Okie dokie. Great. All right. Is there anything y'all want to mention that I haven't asked? Okay. Okay. Well, I want to thank you all so much for being here today and for your testimony. We have a couple of follow-ups. Okay. All right. So for Angelique, we're hopeful to have the types of providers and categories of who has provided the audit cost reports. I don't know. Have you guys ever thought about, like, what do they say? Sunlight is the best medicine, disinfectant. Maybe you should just post who sent them and who didn't, and just see where the chips fall. I don't know. Just to see. So for Dr. Walsh and DC Health, we're looking for how many complaints did we get about Maryland or Virginia providers during the waiver period in the public health emergency. Would DC Health be open to Maryland and Virginia folks continuing to practice here if there was a registration process? Is DC Health okay with permanent certification for 16-year-olds and just requiring this CBC when they turn 18? What we're trying to get at there is not having a situation where someone has to pay twice in a year. And then the crosswalk for CNA to HHA.
What's the last thing you said? I'm sorry.
The crosswalk.
Oh, yeah.
Yeah.
That was actually the first thing on my list.
Okay, great. So again, I want to thank all of the witnesses who testified today. The record will remain open until 5 p.m. on March 27th for the public to submit testimony. You may submit written statements via the council's hearing management system on the council website, dccouncil.gov/hearings, or you may leave a voicemail at 202. You know what? Don't leave a voicemail. Please submit. Just submit it written. This concludes our hearing today. The Committee on Health will begin its fiscal year 2025 budget oversight hearings later this month after the mayor releases her proposed budget on March 20th. Our first committee budget hearing is scheduled for Friday, March 29th, where we will hear from the public witnesses on the proposed fiscal year 2025 budget for the Department of Behavioral Health. So that will only be for the public witnesses, and then we'll hear from the government witnesses later. A full list of the budget hearing dates can be found on the DC Council website, dccouncil.gov/hearings. that is the way in which you can sign up for the hearings there as well. For folks kind of wondering where things are going to go, so as I mentioned at the beginning, we did hear a board nomination for the Board of Psychology today. The committee will mark that up next week. There is a portion of the direct care worker bill that will be included in the Health Occupations Revision Amendment Act, which will also be marked up next week. As for the rest of the bill, we will continue to work with the relevant agencies to get to a place. I just want to underscore that I do feel like this is certainly an issue that we have here in the District of Columbia, where we have a lot of individuals who want to age in place. And I don't feel like we have the infrastructure in place to do that. But I feel like we have some time here to get it right if we focus on it and make it a priority. And with that, the time is 5:16 p.m. and this hearing is adjourned. Thank you all.